ठीक है, ये तो मेल खोल दो हो गया।
हेलो माइक टेस्टिंग 1 2 3 हेलो हेलो कहाँ से आ रहा साउंड रानी इसमें से आ रहा नहीं डायरेक्ट नहीं आ रहा उसे ऑफ करके ऑन कर ऑफ करके करो नहीं ओपन भी करना प्लस ये नहीं पहले क्या था ये लैपटॉप को था ठीक है वो वजह से नहीं है
Check. Check. 1 2.
लाइव कर रहा हूँ लाइव है
Check.
चेक कर लिया
Check. 1 2. नहीं आपका स्पीकर कट कर Check. 1 2. Check. Check test. Check. Check. 1 2. Check. Check. check.
बात करो, बात करो।
Check. Check. 1, 2. Test. Check. Check.
Arasa udah. Hello, mic testing 1, 2, 3. Hello.
بسم الله الرحمن الرحيم.
الرحمن علم القرآن خلق الإنسان علمه البيان
بسم الله
Cek cek.
to welcome our esteemed guests.
Assalamu alaikum and a very good morning to all of you. It's nice to see so many nephrologists in our hospital. Well, I always say that in an ICU, when you walk in an ICU, nearly about 30-40% of the patients will be related to the kidneys. It was not so common a few years back, but now as days go on, I think the incidence of kidney disease is prevalent and it is increasing, and 30, 40, sometimes 50% of the patients will have some kidney issues. But unfortunately, the kidney issues don't get solved so easily. Once they go for chronic kidney disease, they only have two options. One is the dialysis or the kidney transplant. And the kidney transplant, hardly any people get this. The number of people who get dialysis is also, I think, only about a very small fraction, a tip of the iceberg. I think gets treatment for kidney disease, and most of them don't get any treatment. It's very unfortunate that though the treatment options are available, but there are so many obstacles, so many hindrances due to which our patients cannot get the benefits. So we are here today to try to discuss how we could solve these issues and then try to improve upon organ donation. It's a pleasure to invite you all, sir. I invite Dr. Professor Sridhar. He's the HOD of Victoria Hospital. He's our consultant. Yeah, very dedicated doctor in our hospital. I invite Dr. G.K. Prakash. He's a consultant from Manipal Hospital. He used to come to our hospital as a consultant maybe around 10, 15 years back. I invite Dr. Ishaq Ahmed. He's the consultant from nephrology and the head of the department of nephrology, and he specializes in all kinds of kidney transplants. I invite Dr. Gopal Krishna, senior from Narayana Health, Bangalore. I invite Dr. Akhil. He's here. He's our friend. He also comes to Shifaa Hospital. He is a nephrologist. Now he's partly in Baptist Hospital. Dr. Mohammed Fahad, consultant nephrologist from Manipal Hospital. And Dr. Naseem Seth, a leading physician who is our neighbor, is also around us. And a budding nephrologist from BGS Global Hospital is amongst us. Yeah, I invite you all. We'll try to discuss as to how we could improve the various options or the various treatment options for the patients that we have. It's a very large area. India is known as the capital of diabetes and the capital of probably the heart failures and heart attacks. And probably if you do a survey, I think we'll also be the capital of kidney diseases because of the prevalence of diabetes, which is increasing day by day. I welcome you all, sir.
The session will be actually chaired by Dr. J.K. Prakash with co-chairing with Dr. Sridhar. We can start the program. Yeah, it's a great pleasure for me to be here after a long time. As Khan was saying, I think we did lay the foundation here in this hospital long ago, courtesy our Altaf and Mushtaq, who happened to be my classmates. One from Davangere and the other one from Mysore, probably, correct? If I'm correct. Yeah. So anyway, let's start the today's deliberations. I think the first one would be, yeah. So clinical and legal implications of brain death, which is going to be deliberated by Dr. Gopal Krishna. Why are we having this clinical and legal implications of brain death is also important to know that, like Khan said, we will be the capital for chronic disease in the world. But the prevalence of CKD in the world is around 9%, and 1/3 of it is family. So that is, and the uh, is a topic and also just so cancer or just people per die of half year. The reason ailment, the percentage of who get some kind of a transplantation done. And the most common one, the cornea. Cornea, I think it started with cornea, and that is all of us to have organs donated. Salutes to those people who really work day in and day out to get this cornea. So the number of cornea transplants being done is around 25,000, I believe, 25,000 per year, and required is almost 10 times. So this is a gravity of problem with regards to various organs what we have, and to meet up with that number it is very difficult. So we definitely need to have deceased donor other than live transplants. So brain death has come in a big way from 1994 when the Human Organ Act was passed, and subsequently some changes have been made in 2011. And it's good that there are a lot of changes which have happened in the 2011 human. Let's hear Dr. Gopal Krishna about them. Any issues will be there, let's have them. Over to Dr. Gopal Krishna.
Good morning, everyone. My sincere thanks to Dr. Ishtiaq Ahmed sir and the organizing committee to have given me this opportunity to deliver this talk that's on brain death. So let's see. The slides are not moving. So today, briefly, I will discuss about the clinical and the legal implications of the brain death. Now, death, the change in the status from a living person to dead is not a clinical phenomenon. Okay. Anyway, we are doctors. We face death almost every day, and over a period of time, probably we become quite medical. And that's how we proceed to the next cases. But for family and other individuals, it's not just a clinical phenomenon. It has got a profound psychological, legal, moral, religion, as well as economic implications that we know. Now, the dividing line between life and death. For instance, we had a patient who developed severe degree of encephalitis, herpes encephalitis. She was treated in local hospital, and subsequently she developed a massive cerebral edema, and then she coned. And in that state, she came to us. When we examined her, we found that she is almost nearly brain dead. However, there was no somatic death. Based on the request of the family, the patient continued on a life support system for a few days, but subsequently they opted to go out. Now, the dividing line, for instance, a person who is brain dead or severe hypoxic encephalopathy versus the death, the dividing line is actually very narrow during at that point of time. For me, what I personally feel, that prolonging of the life solely based on the life support system has significant questions regarding the quality of life of a person. I believe strongly that what is the life? What is the meaning of the life if a person is continuously ventilated, for instance, for months or years? So this is the most important thing, and awareness is required at this point of time, both by the family and the individual when we are surviving. For instance, I would not like to just survive for the sake of surviving and being on ventilation for months and years. Therefore, I have clearly stated to myself and my family members that if I am suffering from an irreversible condition which forces me to be in a condition like brain dead or near brain dead, where a significant recovery and quality of life is not possible, then care should be withdrawn from me. That's what I have informed my family members. and this is an individual decision. We'll look into the legal part in course of time. Now, at the same time, what has opened up here is that it has opened up the vast opportunity for procurement of the organs, which could be utilized for transplantation, and other individual members of the society can lead a productive and fruitful life. So when the line between death and life becomes blurred, particularly in these debatable situations, scientific and legal debate, then the efforts should be made to define it in accordance with the new scientific criteria, and the legal validation should modify in due course of time. One of the most important points which I would like to make here, as per my review of literature, I did not find a single adult, and there are no published reports of neurologic recovery after a diagnosis of brain death. So once we have made a brain death diagnosis, even if the heart is beating, I am yet to see a published case report where that person had a meaningful neurologic recovery. That means brain death, actually it is near, though the patient may be on life support system, these individuals have not made a significant clinical neurologic recovery. So what is brain death or brain stem death? Clinically, death is, as everybody knows, is a complete and permanent cessation of circulation, respiration, and brain. So three functions, the heart, lungs, and brain functions as irreversibly ceased in that individual. It is the irreversible cessation of all vital functions, especially as indicated by permanent stoppage of the heart, respiration, and brain activity. And this is what death is traditionally. The determination of death has gathered much significance in the context of organ donation. Now, when we are talking about organ donation, we are talking about the brain death. At that point in time, the heart is beating, but the patient is brain dead based upon certain clinical criteria, which we are going to discuss. Now, for a successful transplant, the organs should be immediately after the death of the donor. After death, the organs will undergo molecular change. Okay, so as the time passes, after the brain death of a given individual, there will be a lot of molecular changes. There will be changes in the tissue, and what happens? Then the viability, the vitality of the tissues and the organs are going to be lost, except in rare cases, that is of the cornea. Now, only those organs which are being perfused by a beating heart or have received perfusion until recently can be effectively used for transplantation. So once we declare the brain death, then procurement of the organ need to be done at the earliest, because in due course of time, there will be cellular, molecular, and other tissue related changes, and then the effective transplantation will not happen. Now the WHO, that the glossary of terms and definition on donation and transplantation in 2009 defines brain stem death as irreversible cessation of cerebral and brainstem function, which is characterized by absence of electrical activity in the brain or blood flow to the brain, and brain functions as determined by the clinical responses, which I will discuss later. So that means it is a state where there is irreversible cessation of brain as well as brainstem functions, which we mostly determine by clinical examination. A brainstem dead person is dead. This is very, very important. A brainstem dead person is actually dead, although his or her cardiopulmonary functions may be artificially maintained for some time. In general, 97% of the individuals have died if there is no organ transplantation. In that scenario, nearly 97% of the individuals have died maximum within 1 week or 2 weeks. There are very, very rare case reports where some individuals have continued the life support system. They have not made meaningful recovery, but they have continued their life support system for a few months, or there is rarest of the rare reports of about a year, but they have not made any meaningful recovery. So a brainstem dead person is actually dead, although his or her cardiopulmonary functioning has been artificially maintained. In the case of brainstem death, though there is a complete and irreversible loss of all brain functions, the heart will be still beating, thus making the right time to procure organs from the deceased body. So it is this time when the brainstem functions have ceased, the heart is beating and the organs are perfused, that is the right time for procurement of the organs. Therefore, today it is an accepted notion that even if a person's heart is beating, he can be declared brainstem dead. Thus, in simple words, a person is brainstem dead when all the functions of brain ceases. Brain monitors, or brain is the vital organ which will regulate the functions of other organs, So once there is irreversible cessation of brain functions or brain functions, a meaningful neurologic recovery in this individual does not happen, even if there is a, even if the patient can be maintained on cardiopulmonary functions based on support system in the current modern. So then comes the THOTA. The declaration of the death by brainstem death criteria has been given a legal recognition in India in the Transplantation of Human Organs and Tissue Act in 1994. That is the THOTA Act 1994. In India, the determination of death using brainstem death criteria is generally used only in the context of organ donation, and that too in recognized institution where transplantation surgeries can be performed. The brainstem death can be certified by a board of medical experts nominated by the registered medical practitioners from the panel names approved by the appropriate authority. For example, in our institution, many neurologists are there. But pending the approval by the ZCCK committee, those neurologists are not, they cannot declare brainstem death. For example, we have many neurologists, but only few names are approved. So the approved should be there, and these individuals will be called at the time of brainstem certifications, particularly in the context of organ. So there are 4 members are involved. Number 1, the registered medical practitioner in charge of the hospital. Number 2, the registered medical practitioner nominated from the panel of names approved by the journal committee. Then a neurologist or a neurosurgeon. A neurologist or a neurosurgeon should be there in the committee from the panel of names approved by the appropriate competent authority. And the last, that is RMP treating the deceased person. So in India, okay, to avoid any kind of controversies, that there is a brainstem death, as per the law, 4 individuals, these are the 4 individuals that are involved in declaration of brain death. 4 individuals are needed. And whenever the case is there, they will try to notify us, and these individuals and the criteria and the law, they will be the committee in that particular case, and these individuals will to declare the death. But there are, in outside countries or some other countries, there may be 2 individuals may be required. But as of today in India, we need 4 individuals. The rules also prescribe tests to be followed. It is clearly stated that what are the tests to be done? It must be done, and all the forms must be duly filled. All the prescribed tests are required to be repeated after an interval of 6 hours. In India, what is the rule? You declare the brain dead now, then after 6 hours, you repeat all the tests so as to avoid any controversy or make sure that the patient is actually brain dead, not that there are any controversy between set of tests done at say 0 hour and at 6 hours. So in India, there is called single brain death declaration and there is double brain death declaration. So in India, as per the law, we follow double brain death declaration. That's 0 hours, and then after 6 hours, we have to repeat all set of tests to ensure that there has been no observer error and persistence of the clinical state is documented at 6 hours. It is to be noted that the diagnosis is based on clinical examination. Very important thing to note here that the declaration, brain death declaration per se, does not involve anything clinical. It is only clinical. No tests are required. But when the patient comes, then he will require investigation and you will have some information from those investigations. That's a different thing. But when it comes to declaration of brain death, it is a clinical diagnosis. In India, it's a clinical diagnosis. I will talk about the ancillary test in due course of time. The neurophysiological or the imaging study neither forms a part of the diagnostic requirements nor is legally required. Confirmatory tests may, however, be carried out if the panel of doctors is in doubt or there is a disagreement in the diagnosis. Now, you may order these investigations if there is a doubt. But if the committee, that 4 individuals, declares brain death based on their clinical examination, then that is the right path. No ancillary tests are required. Only in rarest of rare situations, the ancillary investigations will be required in certain specific conditions. In India, a panel of 4 physicians, including treating physicians, a physician representing the treating hospital, an independent specialist, and a neurologist or a neurosurgeon is convened to determine brainstem death, along with the registered medical practitioner who in charge of that particular hospital. Now, before submitting somebody for a brainstem death or before declaring the brainstem death as a prerequisite, exclude. It is our fundamental job to rule out a reversible causes of coma. Reversible causes of coma must be ruled out. And what are the reversible causes? For example, severe degree of angiodigestion, or the patient might have used muscular agents, or the patient may be taking some CNS depression medication, or severe hypothermia, or severe hypovolemic shock, or endocrine conditions like severe hypocalcemia. All these reversible causes of coma and complicated with medications. For example, a patient is having severe degree of hypothermia, particularly in children, and then superadded they have got a septic encephalopathy and severe metabolic acidosis. Their EEG may look flat, and the child may look almost brain dead. But it is extremely important for us to rule out reversible causes. That is step number one. Then clinical or neuroimaging. When you see these patients, we have some prior information. What is the cause that lead to a brainstem death? That we need to know. A clinical or neuroimaging evidence of an acute central nervous system catastrophic event that leads to this brain death with compatible diagnosis of brainstem death should be established before subjecting a person for further testing of brain death. So, for example, these are what are common causes that we encounter. One could be a traumatic brain injury. Like we see many young individuals, they will have a road traffic accident. They will have no other organ problem. They will have a road traffic accident. Then the CT scan will show diffuse axonal injury. And then within, say, 1 or 2 days, they will be brainstem dead. Other organs are perfectly functioning well. That is one of the common scenario that we see. Another is post-cardiac arrest hypoxic encephalopathy, or a patient with brain tumor, for example, a third ventricular cyst or a large brain tumor. Then a malignant MCA territory infarct. These are the common clinical scenario where the patient can be brainstem dead, but other organs may be functioning. Now, for example, this is a CT scan. This is a CT scan of a patient with a traumatic brain injury, which shows a significant amount of diffuse cerebral edema, and he had a diffuse axonal injury. This is, you can see that the left hemisphere of this patient is fully infarcted. It looks quite black, and then significant amount of mass effect. So we know, apparently, we know the cause of the patient, that these patients may not have any meaningful recovery even if they survive. So this kind of information is there with us prior to declaration of brainstem death. So assessment of the brainstem reflexes should be done using a series of tests, which are clinical tests, and this must be repeated within an interval of 6 hours. So it's clinical. It's a pure clinical diagnosis, clinical and bedside, and clinical and imaging evidence of an acute CNS catastrophe should be known. We have to rule out reversible causes like drug intoxication, poisoning, and sedation. And then comes the neuroexam. So now, by this time, we know what is the cause which led to a scenario of brainstem death in that individual. Maybe a severe hypoxic injury, or maybe a subarachnoid hemorrhage, or a brain tumor, or a large infarct, or severe traumatic brain injury with diffuse axonal injury. We know all things. Now then establish coma. You give deep painful stimulus, the patient do not respond. Then do genetic motor response to pain as the absent. Then check the pupillary responses. Then we check the corneal reflexes. Then we do the oculocephalic oculovesicular reflex in the bedside. We check the jaw jar. We check the gag reflex, and we check op reflex. These things can easily be done in the bedside. Okay. And all these brainstem reflexes are going to be absent in that patient. After all these things are done, then we go for something called as apnea test. Now, in apnea test, what they do is they pre-oxygenate the patient and then ensure that the patient is not hypocarbic by ABG, then disconnect the ventilator but supply the oxygen, then monitor the patient for any signs of respiration. Then obtain the ABGs at selected intervals. Then you analyze the test. What can happen? Stop the test and return to the mechanical ventilation if there is hemodynamic instability. The patient exhibits force, patient starts breathing. Or if your or there is an increment by 20 millimeter of mercury above the line in a setting where the pH is less than 7.3, where you call that the apnea test is positive. So we did a clinical examination, we checked all of the reflexes, then we finally did the apnea test. Now, once we have finished this, then we declare that the patient is brainstem dead, and then what we do is that we have to come back again after 6 hours and repeat all this set of tests in that particular individual, or the 4 members will come, reassess the patient clinically, because it's in India by legal means it's a clinical diagnosis. So now important thing which I would like to highlight, which is important for physicians as well as for the family members, what happens in patients with brain death is that the movement sometimes what happens is the patient is brain dead, but the spinal cord or peripheral may be active. Some movements may be originating from spinal or peripheral nerve may occur in patients, and it can be seen in various series. Minimum we see around 15% in many series it is there, but in one of the American series showed that nearly 33 to 75% of patient brain patient can have some movement. Now that causes confusion. Sometimes a family member will come and say, "Doctor, today I saw that my relatives the hand is moving, and how do you say that the patient is brain dead?" Okay, so this causes a lot of confusion, and they need a lot of education. And these are triggered. These are mostly, and whenever you touch, then there is some movement, and mostly these are triggered by tactile stimulus or occur sometimes can occur spontaneous. So what are the movements? Sometimes semi-rhythmic movements in the so facial nerve is denervated. So you may see some facial quivering movements, or sometimes you may see finger flexion movement, or sometimes even neck flexion movements we can see. These are called Lazarus signs. So these movements are not originating from the brain, but they are originating from the spinal cord. This movement does not mean the patient is not brain dead, and that is very very important. And this sometimes causes confusion to the family members. But again, we have to counsel them, explain them, and educate them. For example, can you play this video? Click the down. Just click in the center, it will run. Huh? Okay, or else independent video is play there. Another file is there, and then come back to the folder. It's working there. Just see, you remove this and play that video so that audience. Just that video. This. So when the physician is examining, you saw that finger movement. So this kind of movement may be possible. So when the family go to the slide show. So when the family members will come, they may give some stimulus. Then there will be some movements, and then it causes confusion. So most important to recognize that this kind of originating the spine or the peripheral are possible. This does not mean that it's not. Go to next slide. I'm not able to do. Okay. there will be problems in the clinical assessment, or like a brain spontaneous bleed, for example. So these patients, okay, initially before after the cardiac arrest, and then when the patient will have a spontaneous circulation. So these are the situations. Yeah, and when the etiology of brain death is not clear, and patient's family not accepting brain death. Like for example, there are moments, and the relatives will tell that no, my patient is not dead, and then at that time you may use ancillary investigations. Like again, I told abnormal movements regarding the. So there comes the ancillary investigations. Now, ancillary investigations, one of the most common ancillary investigation that we use EEG. Though EEG is not gold standard, because these patients sometimes they may be hemodynamically unstable, and shifting these patients are also great challenge. So then we do something called as EEG because it is quickly be done. The machine can be brought to the bedside. So EEG is one of the common investigations that we do. And in EEG, what we see is called electrocerebral silence or electrocerebral inactivity. It is defined as the absence of EEG activity in 2 microvolt sensitivity, even during auditory and nociceptive stimulus procedure performed on both sides without any possible objection. So we see the EEG at a sensitivity of 2 microvolt, and if there are no brainwave forms, then we say in the 30 minutes record that the patient is having electrocerebral silence. It should be done minimum for 30 minutes. As compared to the standard EEG where you use many electrodes, here minimum 8 electrodes are also sufficient. And the filter setting, which is a technical. Now, another important thing that technical part, that when we do EEG, that there should be no hypothermia. EEG should be done after cardiopulmonary arrest. EEG should be done after 12 hours. And note should be made that this patient should not be on sedative medications, or as far as possible, the metabolic parameters need to be corrected. For example, this is one of our patients. Okay, we are seeing the EEG at a sensitivity of 2 microvolt. Okay, and this patient is clinically brain dead. She had got a severe degree of viral encephalitis. And then when we see there are no brain activity, what we are seeing, this is the artifact. And at 2 sensitivity also, there are no brain wave forms. Now, same patient, okay, so there are no brain wave forms. We are seeing some kind of only artifacts in this patient. So, same patient, you see, when I'm increasing the sensitivity, normally we see the EEG at around 7. Now, at 5, it looks completely flat. So, this EEG qualifies. So, this is an ancillary test. When there is a doubt, this EEG will help us in declaring brain dead in some individuals. But as of now, in India, if clinically somebody is declared brain dead, then we don't need ancillary investigation. Ancillary investigations to be done only when there are some issues in performing the clinical examination of the patient. So this is another ancillary test, like for example, angiogram. When you do angiogram, then you don't see cerebral circulation. This is the carotid injection, and this is the carotid injection. So what happens is that when you give dye to this patient, intracranial, you see the extracranial part, but intracranially there is no circulation in this patient. So these are the ancillary investigations that can be done. Other ancillary investigations commonly use the transcranial Doppler or radionuclides. So there will be no radionuclide uptake in a patient who is brainstem dead. Among all the ancillary tests, there is DSA or angiogram is considered the gold standard ancillary test, and this will lead to absence of filling of the 4 vessels. There is 2 internal carotid arteries and the vertebral arteries, as their course becomes intracranial with a patent external carotid circulation, and this is corroborative of brain death. So, but the problem is that this is say for example, this patient will have other organ dysfunction, challenges are there, you have to shift the patient to a cath lab. That is why EEG can be easily performed in the bedside. So that is why EEG is one of the very common tests which is being used in many countries. But if there is a doubt, this is one of the tests which can be done. The clinical diagnosis of brain death is the gold standard, and ancillary tests can confirm the brain death when clinical testing cannot be performed. Determination of brain death using brainstem death criteria is the integral initial step towards organs for transplantation from patients who suffer from catastrophic brain injury or apneic coma. Despite the fact that I told you that 1994 it came, despite the fact that 25 years have passed since Indian law has defined brainstem death and has laid down procedure for the declaration of brainstem death. Medical, social, religious, and legal controversies still exist. And that's the most important point. It needs awareness among people and among the society. Then we need to understand very clearly that if once a person is declared brain dead, there is no meaningful recovery. In fact, brainstem dead means that person is dead. Only through artificial support system, the person can carry out for few more days to proceed with something called as the final somatic death. To improve the public's trust in organ donation, the government and the professional societies to develop initiatives to promote brainstem death determination and credentialing program to ensure that the determination of brainstem death is consistent, accurate, and flawless. Because sometimes the public will challenge, oh my God. So therefore, that increasing awareness is the most important thing in the society, so that people will understand all these things, so that the people those who are waiting for transplant may be helped. So now in India, we have got two declarations at 0 hour and at 6 hour. Now, as per the law, we have to follow. But just present one review article before you. So, comparison of one versus second brain death examination on time to death procurement and organ donation. Now, this is a study which is published in American Academy of Neurology journal from United States. Just we'll take a very quick look. So, here 266 patients were declared brain dead, and 122 after single declaration and 144 after double brain declaration. The time from the event to brain declaration was long of 20.9 hours after double brain death declaration, and 27 that is 73% families of the patient with single declaration and 86 with double brain declaration actually consented. That not that you declare. So it needs the counseling system and the coordination should be so robust that the patient, the people those who are consenting, actually they will consent from the very beginning. The people, I have seen many families, when they try to consent after the second declaration, in fact, finally they do not consent for anything. And then finally they go. That scenarios are also well prevalent. So that actually is validated in this study. The number of brain death examination was not a predictor for the consent. Okay. So no patient regained brain functions during the period, during the following of brain death. Patient with a single brain death declaration are more likely to have at least one lung transplanted. You see. So therefore, I mean, this facts has already been published. So today for the government of India, the guidelines, but now these data are coming up as more and more organ transplant and brain death declaration is happening. People have started feeling that even the one declaration is enough. That data has been published in American Academy of Neurology journal. So a single neurologic examination to determine brain death is sufficient in patients with non-anoxic catastrophic brain injuries. A second examination is without additional yield in this group, and its delay reduces the number of organ transplants. So to conclude, brain death declaration is a complete and irreversible loss of cerebral and brainstem functions. Brain death is equal to cardiopulmonary death, and even if there is a cardiopulmonary functions going on just because of artificial support system, once the brainstem death is declared, sorry, the patient will not have any meaningful neurologic recovery as discussed. The brain death declaration in India is clinical, and we need to rule out reversible causes of coma. Apnea test to be done towards the last part of the clinical evaluation. Ancillary test to be done only when the clinical criteria cannot be applied or you have challenges in doing the clinical examination in this patient. And brain death declaration in India, as of now, the first and second declaration should be done within 6 hours till further clarification comes from the from a legal point of view. Until then, we need to follow the double brain death declaration in India. So thank you so much for your patient hearing. And if there are any questions, I will respond.
I think that was an excellent lucid presentation on brainstem death. One or two clarifications to make. I think 2011 modification of whatever 94 they're done. In that, what we now understand is that we don't need a neurosurgeon, neurophysician to declare.
Yes.
One physician and anesthetist or an intensivist should be fine enough to so that our your burden has been lessened.
Because so actually it's just the clinical part.
Yes. So that's a very
Yes.
good step taken by the
Yes,
government.
yes. That
And
has been published.
yeah,
Actually, that article also is published.
yeah.
Yes.
And the second thing is you enlightened and made the point on how do we go about declaring brainstem death and educating the public.
Yes, sir.
I think I was just talking to half years and hospital to really utilize what Krishna too. That was a very important, excellent point on your brainstem.
Fantastic. There are, there are donation or cardiac death. People in people deliver. So organ deficit. That's there. So it's a global health problem in WHO. So are very, very less now, actually. No, I'm talking about this. See, I think better to adopt a spike. 90% donor and people live. So how the they have adopted opting out option. Opting out means those are eligible donors means to like that. So they're like they're like eligible donors. They have become eligible donors. So by law, by person, if they want to, they have to the nation. They are declared the donors until they. So that's to catch. And we have opt-in now.
Yes.
So we are
Yes.
opting.
Yes.
My actually was whenever they do better than the driving license. No. Start license, they should come, sir. They are and that is actually what follow that. Good talk. So now why to organ 7 or 8 organ maintain?
Yes. That is now they are in the US and they have their see what is the first decision today with the choice of the patient is going family weekly of the patient, what is the everything we know.
Yeah, sir told one declaration is I think is enough. I still remember Ramalamba. He actually had a head injury in Bangla. He donated actually.
Yes.
So that like see when this any VIP or any one fellow gives no that will become highlighted. So that is a good this one. I think sir has enlightened us very good.
Another
Very
thing what
beautifully.
we need to individual at community level we can educate, number one, and second is that for example, I don't know, I'm talking about a personal thing. Many physicians themselves they may not be knowing whether they would die. That question they not ask themselves. As physician, we haven't asked ourselves, will I donate my organs or what will happen? That picture we have not tried to see actually because it's a little difficult one. Okay, so I mean it should be clear, like organization, even those kind of thing. If we are ourselves and we slowly we can keep telling our other colleagues, then they will be motivated, because as a physician, because we see death and all these things so closely, then we are the best people that where we can take this kind of decisions. I think because even if our close relatives are there, we are in the profession for such a long time and we have been facing this daily. So therefore I think definitely some leadership has to start from the physicians. Of course we have to educate the general public, and then again slowly.
Yes.
I mean
The donation has become more after Punitra Ajumar death. No? Like that, something has to happen.
yes sir, yes,
Yeah, then only I think.
yes.
Thank you very much, sir.
Thank you
Any
so
other
much, sir.
questions?
Thank you.
Sir, one question.
Sir.
Actually, since we manage ICU beds, most of the times we see patients with traumatic brain injury or any other cause with brain death. So it is slightly deviated from the topic, but we are faced with a situation where a patient is brain dead and we don't know how long the patient is going to survive on our system, and we cannot afford. So legally, we pull out the life support system.
The current, that's what I'm trying to tell. In India, what is the legal point? In India, you can discuss about brain death only in the context of organ donation. Rest is blurred. It depends upon your faith and discussion with the patient. It's a total, I mean, there is no answer to your question basically. Discussion of brain death happens only when there is procurement of organs. And the legal point is silent in that area. The question, see, that is why actually the law should gradually start coming. If a patient is, so many patients, like so 10 such patients are there. Again, they are thinking, an important member of those who with some reversible condition can come to the ICU are also not able to come because we have very few ICU beds. So this point is well taken, but this, from legal point of view, this rule has to come. We strong, as I told you from the literature, that a single brain death declared means up to 97% of patients are not recovery. One or two patients will just prolong their life. Whether they will prolong for 1 week or few months, in an individual case, it is extremely difficult to tell. But that point has not come any legal validation actually in India. So therefore, for example, if you remove the life support system, somebody can sue you, and then you will have a tough time. But finally, you can prove that okay, single death is all this data we can take. But whether it will protect us or not, I am not sure.
Yeah, even what you were saying and what Gopal Krishna was saying about the organs can be arrested if you can do what is known as passive euthanasia. It has not been adopted yet. Recently, the government, the law ministry has passed this one, no, that you can actually withdraw. There are three things here. One is voluntary withdrawal, involuntary withdrawal, and non-voluntary. What they are now trying to say is withdrawing the support. That the government is saying, the law ministry has given us one in the paper recently. I don't know how it will be implemented, what are the implications and all that. But that is being allowed, which is a great move by the country, is what I can say. But as of now, you cannot, if we feel that, okay, there is an organ which can be harvested in an ICU setup, this does not apply. So again, separate discussions have to happen, and then the government, the law ministry has to decide. So that, as of now, it is not there. Long way to go, but there is some initial movement which is most welcome, I think.
Correct.
One or two comments I actually want to make is, I'm Dr. Altaf. One, looking at actually post brainstem death. Two, post cardiac death. This whole problem is going to get solved in case if we can find means and ways to harvest organs after post cardiac death. How long can we actually salvage these organs for about 6 hours, 8 hours, 10 hours? Possibly that is going to put all the things to rest, controversies to rest. That, and second, before cardiac death, is it possible to harvest only organ, single organ, like single kidney, single cornea, I mean to say single lung, which is, we have two organs. So that still actually one is there, where the patient by chance is going to survive, though it is not meaningful, but to counsel the attenders. Three, the point which I've learned today is basically, ultimately it is trust. We need to spend a lot of time with the patient attenders.
Yes.
Because this point is especially myoclonic jerks or otherwise spinal reflexes. The invariably patient was not moving, today is moving, and ultimately near and dear one is leaving this world and is a young patient from post-traumatic. Already they are deeply hurt, yeah, about what is happening and trying to counsel them about transplantation. Because this is a practical problem which we're going to face. Invariably, they bounce on us even when the patient dies in natural death, even if he's 70, 80, 90. But when it comes to young patient, because normally this we are expecting in post-trauma, post-cardiac arrest, or patient having malignant tumors, or a malignant CVA is very unlikely. It is about 5% or whatever. So in such cases, basically what, as you rightly said, we need to have CMS like this repeatedly to actually sensitize our doctors presently, because actually it is we ourselves are not aware when really to counsel, what to do, how to go about. Possibly in case these are the things we are going to find post brainstem death, it's a common and symptom. Actually, maximum they are going to survive for a week or two. And actually, one big problem that you're going to encounter is trying to get religious sanction from the actually the clergy. That is not difficult. They cannot give a blanket statement. It's going to be case by case, and that is what we need to remember. So possibly in case if we are clear about what we are doing, and then we keep before them, they are willing to give actually release a sanction for transplantation and say for donation. So basically it's to be possibly some robust system where sensitization of actually doctors who are involved in the care of the patient, possibly it's going to go a long way, and possibly promoting donor actually there's actually a donation of organs. That is what I think so after listening to you that came to my mind.
Yeah. Thank you so much for your
Uh,
feedback, sir. Thank you.
Altaf, I think I'll start with the last comment you made about religion not really supporting. We need to take the permission of various heads of the religious heads, basically. But all the religions, including Hindu, Christian, Islam, even Jainism, they all consider this as an act of compassion and generosity. So that is one. So that is sorted out now. At various platforms, it has been discussed extensively all over the world. So that has been taken care. One. The second thing which you alluded to regarding the post-cardiac death, there is an entity. It is called extended donor donation. What we follow is standard donation, standard criteria donation. The other one is what you are saying is extended criteria donation, wherein post-cardiac death. It's a real challenge to take up such organs. It is not still there in our country. No, in our country, I can say, definitely not in our state, because there are that could be after death. No, there can be some of the complications can arise. The creatinine can go away. They can be oliguric. So many things. So that is called extended criteria donation, which is there in the states. They do that, and the donors, which the recipients whom they will give it to, are again a group only. Say if they are aged, because their longevity is not assured, so they can get and then live for some years. Or if they're continuously cross-match negative positive, they can take. And then if they have any problems with the access, dialysis and all is a problem, you cannot get an what is that, IJN or fistula. Such people may not last long. Such other examples are there wherein they give those kidneys. Not in our country as of now.
Criteria donor. 1 minute, sir. See that I think we should probably Akhil will tell again. There is a mastered criteria donation after cardiac death, uncontrollable and controllable death. I think we'll cover that this one because we don't. Yeah, extended criteria donor is different. That is when age is more than 60 years, 50 years with ICH bleed or hypertension. So these now they are considering it's giving a good result. It's as equal as standard cardiac death, standard brain death like that. Extended criteria donor. We are doing. Everybody is doing that. Regarding the post cardiac death, as soon as there's two criteria, four criteria are there. First two criteria, patient will come, will die after. See, that's what counseling should be started in the emergency department. We should post a medical counselor in emergency department as well as ICU. As soon as the patient comes, no, cardiac death is there. Start counseling the patient attendant, family members. Then, if they agree, no, till that time, after the patient comes, you cool the organs. So that's what. After that, you can counsel. Then, if they agree, you can take, or if they don't agree, you can. If that comes, no, definitely our pool of this deceased donor will definitely increase. We can have more cases of that one.
Any age limit, sir, is for this?
Sir, no age. 70 years, 80 years also they have donated. Sir, no age limit actually. Pediatric, yeah, even infants also they were that one. Infants also, infant, and we have 2 kidneys to only one person. Pair kidney donation. So there's no age limits. If they want to, they're willing to donate. Yes, we'll take all the, and kidney will grow as the this one grow.
Liver transplant has been done for 30 days old kid also. Primary biliary atresia. 30 days liver transplant and excellent results. You won't believe that.
Thank you, sir.
Thank you, sir.
Thank you,
Thank
Gopal.
you.
I think we'll move on to the next. I think it was a very interesting discussion which we had. I think it'll go on and on. I don't think so. There's a time limit for that. So let's not continue further. We can have it during the tea break or lunch break. So the next topic is by our good friend Dr. Ishtiaq Ahmed. He would be talking on scenario of organ donation after brain death. Over to Dr. Ishtiaq.
Assalamu alaikum. Good morning. At the outset, I would like to thank Dr. Altaf and Dr. Mustaq sir inviting us for this program. The whole I got initiated mainly because I came for guidance about organ donation after death. In a very simple way, he said, it's like myself, I have my own about brain death, when you call brain death, what are the legal, what are the implications of brain death and all. Then he said, let us have a semi only on brain death and the organ donation after brain death. So this is the background for this CME activity. I like to thank my good friend, Dr. Gopal. Tell me, he's a very busy person. He works about 15 to 16 hours every day, Monday to Saturday. Neurologist. And when I asked him first time, he said, he'll come. I told him, Bhaiya, it is on Sunday morning. He said, no problem, I'll come. So that's his commitment. I'm really thankful, Gopal. With once I told him, Gopal, I need your help. But thank you, Lord. It's very difficult because we are very busy from to Saturday. And you out a lot in the evening time. So very difficult to face that. Anyways, once again, thank you, Gopal. So today, I'll very, very briefly discuss about donation, brain death, cardiac death. Very, very briefly. I'm not going to, yeah. This is front, no?
This is front.
This is front. Okay. I'm not going to give big lectures on how transplant is done, what is transplant, what are the medical issues with the transplant. I'm just going to maybe very briefly mention about what are the real problems what we face other than the medical issues. There are a lot of medical issues, infection, rejection, all those things. I'm not going to touch those things. I'm just going to see what are the non-medical issues actually patient faces with the transplantation and with the dialysis. I'll start with one of my own patient who is here. He will share his views on his problem also. Now he is 32 years. So at the age of, in 2012, it is not 2013, 2012, he was diagnosed to have chronic kidney disease. So that is, at that time he was only 21 years. At the age of 21 years, he was diagnosed to have chronic kidney disease. In 2013, he was told that he has to go for dialysis, but his condition was not good, and he was forced to go for dialysis, to initiate dialysis in 2013. A small family, father is there, elderly father, a younger brother. For his younger brother, at that time he was only 9 years, and mother. So they started dialysis, then they wanted to go for a transplant. So a middle class family, they wanted to go for transplant. They realized that transplant is easier than dialysis. On long term, dialysis becomes more expensive than going for transplant. The quality of life is better. Even the expenditure wise, if you really calculate, it is much, much better financially to go for transplantations. Anyway, he took a good decision. He wanted to go for transplant. Mother came as a donor. Everything done, all the tests, CT scan, CT angio, everything done, everything was fine. And patient was admitted for transplant in 2013 in Mangalore, AJ Hospital. So the day of surgery, everything went smooth till 8 o'clock. Patient was shifted in. When they opened up donor's tummy, abdomen, laparotomy, or what is the surgical intervention, they saw something. Then they decided not to proceed with the transplant, not to proceed with donor nephrectomy. They told patient that there are some issues in the tummy. We cannot take her kidney. So mother was ready, everything was done on table. The day of surgery, after opening up abdomen, the team decided, maybe with a good intention, not to proceed with transplantation. So he's back on dialysis. No other donors. Father is elderly, hypertensive, not doing well. The other family donor is a younger brother who was only 9 years at that time. So 2016, he enrolled his name for cadaver kidney registration. So 2016, his name was put in cadaver kidney because nobody gets kidney without any registration. You have to register, then you have to wait. So he waited almost 7 years to get kidney from the government or from the whatever the ZCCK or whatever the Jivana Sarthakata. So he was on 7 years on dialysis, not doing well, lost weight. In fact, if you see him now in last 4 months, he has gained some weight. Very, very pathetic situation. And they're not very rich enough to go to a center where they do unrelated transplant, pay money to unrelated donor and get it done from a unrelated donor in a hospital because expenditure will be very, very high. So he's forced to go on dialysis even though he was not doing well for 7 years. He's one of those lucky fellows. He survived and got kidney after 7 years. I'll tell you, there are a lot of patients won't make up for this weight. Good number of the patient we lose, like him. No, very young fellows, 20, 30 years. So they wanted to go transplant. Some money is there. Donor is not there. They can't go for unrelated. Trust me, there are a lot of patients in his category actually. I just want initially him to share his story. Then I'll come back to you, Mallikarjun. This is Mallikarjun, transplant done 4 months back, doing well. He has put on some weight. At the time of transplant, trust me, a lot of fellows would have thought 10 times whether to take him for a transplant or not. He was emaciated, not able to walk, not able to stand properly. That was his situation because he was not doing well on dialysis. This is his mother, who was his first donor, who was rejected for a strong medical reason. This Mallikarjun will share his story. Then I'll come back to original not discussion or topic. Sorry, this is another mistake. Late night I have prepared slide 27, 9, 22. The 4 months back. Last September. No, this is 22 actually. Sorry.
Good morning, everyone. Sir, ನನ್ನ ಹೆಸರು ಮಲ್ಲಿಕಾರ್ಜುನ. ಸರ್, ನಾನು 2012 ಅಂದರೆ ನಾನು ಕಾಲೇಜ್ ಮುಗೀತಿದ್ದಾಗೆ ಏನು ಕೆಲಸಕ್ಕೆ ಜಾಯ್ನ್ ಆಗಬೇಕು ಅನ್ನೋ ಟೈಮಲ್ಲಿ ಸ್ವಲ್ಪ ಹೆಲ್ತ್ ಇಶ್ಯೂಸ್ ಆಯಿತು, ಜ್ವರ ಎಲ್ಲ ಬರೋದಾಯಿತು. ಹಾಗಾದಾಗ ಹೋಗಿ ಚೆಕ್ ಮಾಡಿದಾಗ ಕ್ರಿಯೇಟಿನ್ ಲೆವೆಲ್ ತುಂಬ ಹೈ ಇತ್ತು, 17.7 ಇತ್ತು. ಸೊ ಆಟೋಮೆಟಿಕ್ ಡಾಕ್ಟ್ರು ಏನೋ ಆಪ್ಷನ್ ಡಯಾಲಿಸಿಸ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿದ್ರು. ಅದಾದ್ಮೇಲೆ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಾ ಹೋದೆ. ಅದಾದ್ಮೇಲೆ ಬ್ರೆತ್ಲೆಸ್ನೆಸ್ಸು, ಡಯಾಲಿಸಿಸಲ್ಲಿ ತುಂಬ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಎಲ್ಲ ಬಂತು. ಅದಾದ್ಮೇಲೆ 2013 ಆಗಲ್ಲ ಅನಿಸ್ತು. ಸೊ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟಿಗೆ ಟ್ರೈ ಮಾಡೋಣ ಅಂತ ಟ್ರೈ ಮಾಡಿದಾಗ ತಾಯಿ ಅವರೇ ಸ್ವತಃ ನಾನು ಮಾಡ್ತೀನಿ ಅಂತೇಳಿ ಎಲ್ಲ ರೆಡಿ ಆಯಿತು. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ OT-ಲಿ 2013 ಅದು OT-ಲಿ ಕ್ಯಾನ್ಸಲ್ ಆಗ್ಬಿಡ್ತು. ಮತ್ತೆ ಅಲ್ಲಿಂದ ಹೀಗೆ ಡಯಾಲಿಸಿಸ್ ಕಂಟಿನ್ಯೂ ಮಾಡ್ಕೊಂಡು ಮಾಡ್ತಾ ಬಂದೆ. ತುಂಬ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆಯಿತು ಮಧ್ಯದಲ್ಲಿ. ಸೊ ಕ್ಯಾಡವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಬಗ್ಗೆ ಅಷ್ಟೊಂದು ಐಡಿಯಾ ಇರಲಿಲ್ಲ. ಬಟ್ ಯಾರು ಹೀಗೆ ಒಬ್ರು ಹೇಳಿದ್ರು 2016 ರಿಜಿಸ್ಟರ್ ಮಾಡಿದೆ. ಸೊ ಅಲ್ಲಿಂದ ಮತ್ತೆ ಇದೆ ಡಯಾಲಿಸಿಸ್ ಕಂಟಿನ್ಯೂ ಆಗ್ತಾನೆ ಇತ್ತು. ಮತ್ತೆ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಬರ್ತಾ ಹೋಯ್ತು. ಸೊ ಕ್ಯಾಡವರಿ ರಿಜಿಸ್ಟರ್ ಮಾಡಾದ್ಮೇಲೆ 2016 ಮಾಡಿ ಆದ್ಮೇಲೆ 2022 ಸೆಪ್ಟೆಂಬರ್ 27ಗೆ ಕಾಲ್ ಬಂತು. ಆಕ್ಚುಲಿ ಒಂದು ಊರು ಮ್ಯಾಂಗ್ಳೂರು. ಇನ್ನೇನು ಹತ್ರ ಬರುವಾಗ ಕೋಆರ್ಡಿನೇಟರ್ ತುಂಬಾ ಚೆನ್ನಾಗಿದ್ರು, ನನಗೆ ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡ್ತಿದ್ರು ರೆಗ್ಯುಲರ್ ಆಗಿ. ಅವ್ರು ಹೇಳ್ತಾ ಇದ್ರು, ಇನ್ಫಾರ್ಮ್ ಮಾಡ್ತಿದ್ರು. ಸೊ ನಂಬರ್ ಹತ್ರ ಬಂದಾಗ ನಾನು ಮ್ಯಾಂಗ್ಳೂರಿಂದ ಬ್ಯಾಂಗ್ಳೂರ್ ಶಿಫ್ಟ್ ಆದೆ. ಸೊ ಅಲ್ಲಿ ಬಂದು ಆಮೇಲೆ ಡೊನೇಷನ್ಗೆ ಕಾಯ್ತಾ ಇದ್ದೆ ತುಂಬ ಟೈಮಿಂದ. ಸೊ ಫೈನಲಿ 2022 ಅವಾಗ ಸರ್ ಬಂತು. ಸೊ ಫ್ಯಾಮಿಲಿಗೆ ಅದು ಒಂದು ಡಯಾಲಿಸಿಸ್ ಕಂಟಿನ್ಯೂ ಮಾಡ್ತಾ ಹೋದ್ರೆ ಸ್ವಲ್ಪ ಬರ್ಡನ್ ತುಂಬಾ ಆಗುತ್ತೆ, ಫ್ಯಾಮಿಲಿಗೂ ಬರ್ಡನ್ ಅಂಡ್ ನಮಗೆ ತುಂಬಾ ಸ್ಟ್ರೆಂತ್ ಇರಲ್ಲ ಆ ಟೈಮಲ್ಲಿ. ಹೋಗ್ತಾ ಹೋಗ್ತಾ ವೀಕ್ ಆಗ್ತಾನು ಹೋಗ್ತೀವಿ. ಸೊ ಇವಾಗ ಐ ಆಮ್ ಫೀಲಿಂಗ್ ಮೋರ್ ಬೆಟರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
If you have any questions to him, I think he'll try to answer. Otherwise, I'll call.
2012 ಕೆಲಸಕ್ಕೆ ಟ್ರೈ ಮಾಡ್ತಾನೆ ಇದ್ದೆ. ಪ್ರಾಬ್ಲಮ್ ಏನು ಅಂತಂದ್ರೆ ಡಯಾಲಿಸಿಸ್ ಮಾಡಿಸೋದ್ರಿಂದ ಸಾಮಾನ್ಯವಾಗಿ ಎಲ್ಲೂ ಕೆಲಸ ಆಫರ್ ಮಾಡಲ್ಲ. ಸೊ ಅಲ್ಲಿ ಪಾರ್ಟ್ ಟೈಮ್ಸ್ ಮಾಡ್ಕೊಂಡು ನಡೀತಾ ಇತ್ತು. ಬಟ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಇದು ಮಾಡೋದ್ರಲ್ಲಿ ಎಜುಕೇಶನ್ ಇಲ್ಲ. ನಂದು ಆಟೋಮೊಬೈಲ್ ನಂದು ಆಟೋಮೊಬೈಲ್ ಫೀಲ್ಡ್ ಅಲ್ಲಿ ಹೋಗ್ಲಿಕ್ಕೆ ಹೆವಿ ಆಗುತ್ತೆ. ಅದಕ್ಕೆ ಬೇರೆ
Sridhar, I'll tell you, forget about working. He was not in a position to come to hospital for dialysis. That was his situation. No, last 4 months, there is dramatic turnover. Trust me, he was, forget about working. With great difficulty, he used to go to dialysis unit for dialysis. That was his situation.
His brother, younger brother, donated. See, after that, he lived for almost 31 years. See, he became a dermatologist and had a very good. He was a very good dermatologist in Ballari. His practice was very good. He was on just 2 drugs, azathioprine and Visalan. Azathioprine was 50 milligram and Visalan was 5 milligram. Recently, 2 years back, he succumbed to COVID in Narayana only. His name is Dr. Vijay Shankar. Yeah, Dr. Vijay Shankar. Yeah, he has opened this.
I have seen this patient.
Yeah, Vijay Shankar. Vijay Shankar. He is my classmate.
One of my
2 years back, almost 31 years, he had married 2 children and 2 children. And now they're grown up. They both are doing engineering. See, that is the power of transplantation. So this I keep on telling. See, 31 years he lived without any complication. He died of COVID. Otherwise, definitely would have been. He would have been a role model for us. Vijay Shankar. He only arranged our all. We met alumni met in Zindal. He only arranged everything. Yes. Dr. Vijay Shankar. His name is Vijay Shankar. I still remember him.
I was there when we lost him. No, I was doing COVID duties, so I know how he came, how he went down, everything. Okay, thanks, Mallikarjun. Thanks. I think for most of us here, this is one more case where patient got dialysis, then he went for transplant. For me, the 7 years of, no, almost 10 years of dialysis, the amount of money he has spent on dialysis, and I'll say that he's extremely lucky that he survived till transplantation. Most of the patients, either they'll stop dialysis or some infection will come and we'll lose them. They're very young. See, if we had a good system, he would have got kidney transplant long back. There are so many patients dying here, brain death and getting wasted, buried or burnt. So many patients died. If you mobilize 10% of the potential brain dead donors, I'm not saying all, 10%, most of these patients would have got transplant long back. Anyway, that is the story. This is my slide actually. I don't have much to say. This is my whole theme of the whole my presentation. There are a few more slides I would like to discuss, mainly for other reasons. Why there is increasing demand for organs now? So it is, when I say organ, it is not only the kidney. Now it is liver. I told sir that recently we did one liver transplant for 30 days old kid. After 7 or 8 years of marriage, lot of difficulties. Finally, one kid came, primary biliary atresia, not doing well. Transplant for 30 days old kid, and kid is doing well. So why there is increasing. It's not, when we say organ, it is not only for me, it is not only kidney, it is like kidney, heart, pancreas, liver, intestines in few centers. It is not only kidney or liver or heart. There are so many organs. I'll touch that later. Why there is increased need for organs? One is, as Dr. Shifaa said, we are the capital of diabetes, and we have a lot of organ damage, dysfunction, functional, complete irreversible organ damages because of diabetes only. The higher the percentage of diabetes in the population, higher the damage, higher the prevalence of end organ damage, either requiring dialysis, then transplant, kidney, maybe liver, or maybe many. So there is one reason why the numbers, the need is more. It is because of diabetes. It is not only diabetes prevalence. For some genetic reasons, our race is more prone for diabetic related complications. It is not only the diabetes. Everybody with the diabetes won't get kidney damage. If you see a diabetic kidney damage, once again, I'll restrict myself to kidney here. A diabetic kidney damage is more commonly seen in 5th and 6th decade in abroad, maybe Western countries. But if you see in Indian scenario, it is 2nd and 3rd decade. Most of our patients are in this age group. So almost 20 years, productive period of the person is gone with this end organ damage. So it is not only the diabetes numbers. For some genetic reasons, our race, whether you are Hindu or Muslim or Christian, doesn't matter. For some reasons, it is we are much more prone to develop diabetic related organ damages. The other thing is awareness and diagnosis. Now, there is some improvement in our overall health structure. If you go to a small village also, some doctor is sitting there, patient may go there with a history of breathing difficulty. See, initially it was any person who has a breathing difficulty, it is a heart disease, heart failure. But now it is not like that. If he goes, there is some improvement even in the village level, in the primary healthcare level. He will say, oh, he will do echo. There will be echo available. There is a creatinine test available. He'll say, see, your kidneys are gone, your heart is gone, your liver is gone. That was not there. That is the other reason. More and more awareness and diagnosis is happening. Patient is saying that, yeah, my relative died because of liver failure, or he will say that my patient died because of kidney failure. Initially, all deaths, all labeled as cardiac death. The other one is life expectancy. For some good reasons, our life expectancy is going up. When it goes up, naturally, that related diseases also will go up, and the need for organs also will go up. I feel there are a lot of other reasons. These are the few important reasons why there is significantly increasing need for various organs. Now, about what are the donors? There are 3 types of donors. One is live related donor. If I have a kidney problem, for me, my dad, my mom, brothers, sisters, my wife, my kids are the related. That is the legal definition. My mama, my chacha, my fupa, or whoever it may be, they become unrelated. So it is live related, live unrelated. My father-in-law, my mother-in-law, they all, my wife is, even though medically, genetically not related, they're related. But all the others, my chacha, my father's brother will become unrelated. So unrelated transplant doesn't mean that it is an illegal transplant. The unrelated still can be a legal transplant. So there is a related donor, live unrelated donor, maybe totally unrelated, or maybe distant relative, or maybe friend. So this is one more set of donors. This is donation after brain death. What my friend Gopal said, brain death. Brain is dead. A person is, for all practical purpose, dead, but still heart is beating. It may continue to beat for a few more days. Very rarely it may go up to years if you really support them well, but there is no chance of recovery. But patient can be there on life support or advanced support for a much longer time. There are about 3% of the patient can survive for months to year after declaration of brain death. But as you said, very clearly he has said there is no case reported till now where patient has made recovery after declaring brain death. Only thing his misery would have been prolonged because of our intervention. So this is donor after brain death. Brain is dead, but still heart is pumping, the vital organs are getting blood, liver is getting blood, kidneys are getting blood, so still it is working. And there is one more entity, donation after cardiac death. Means brain is also gone, cardiac also has stopped. There is no cardiac activity, no pulse, no BP, nothing, no cardiac activity which can be demonstrable. This is one more group where we call donation after cardiac death. So what is the scenario of, I'm not going to touch live related donation, live unrelated donation. I'll try to keep only hereafter discussion, it will be only on brain death donors and cardiac death donors. If you see the scenario of donation in our country, in the Western countries, developed countries, in developed countries, about 30% of all transplant is live donation. That means 70% is related to brain death or donation after cardiac death. Only 30% is live related donor or live unrelated. Basically, live donors. 70% is cardiac or brain death donors. But see, in our country, 90%, 95% of all transplants are related to live donors. In fact, they say up to 99%, but I have taken as 95%. Only 1 to 5% that there are few states the brain death donations are more. Maybe roughly you can say 1 to 5% is donation from brain death or cardiac death. So it is not a very healthy number, because we should try to utilize more and more brain death or cardiac death donations. Because what you say, there will be some risk for the donor. Emotionally, we may say that, okay, no problem and all, but we know that on long term, there will be some secondary effects on the donor. So this is very bad trend. This trend has to change. I'm sure that it will change because that is the need of society. So few words about donation after cardiac death. Here it is, as I told you, it is no activity at all, no brain activity, no cardiac activity. No, that means patient has stopped everything. Here there are a lot of challenges because after cardiac death, we don't have much time. We cannot keep this patient on artificial support. Now we have to remove these vital organs immediately, because there is no perfusion of the other organs once there is no beat. But there are a lot of challenges here. Only in addition to the regular challenges here, mobilizing a patient for a retrieval of organs within a short time. Sir asked one good question: how long we can use these donors? For kidney, they say maximum 1 hour. After that, it becomes useless. How it is possible for us after death, within 1 hour, you remove the organs? It's very, very, very difficult. A lot of logistical issues are there. But anyway, good news is that still things are moving in a good direction. If you see 2021, there are about 8,000 donations after cardiac death all over the world. 8,000 cardiac death related donations in 1 year. Sad to say that not even one from our country. Not even one in this period, that is 20 to 21. Most of the cardiac deaths, as Dr. Prakash said, it is from Spain, a small country. There everybody is a donor unless you opt out. You have to write letter, or you have to inform the government, I don't want to be a donor. then only your name will be deleted. Otherwise, automatically, there is no question of taking consent and all. Once brain death declared, and you go for a donation. So Spain does maximum number of cardiac donation after cardiac death. The other countries, USA is doing very well, Canada is doing well, France is doing very well. So these are the few countries they're really doing well because they have classified these cardiac donors, cardiac death donors, into two groups. One is controlled group, or other one is uncontrolled group. Controlled group is we know that patient is unwell. Anytime we may lose him, and you prepare the logistics for the retrieval of organs. Uncontrolled group, somebody and he can move the organs. That is uncontrolled. Controlled means most of the time patient is already there in the hospital. We know that he's sick, or maybe in some conditions already brain death is declared, but logistics are being taken care by the time he dies. All those things becomes uncontrolled donation after cardiac death. So right now, most of the donation what is happening after cardiac death is controlled donation after cardiac death. That means we know that patient is very sick. Anytime he may die. A few patients already brain death declared, but cardiac is still there, but he stops. Everybody is prepared and go for a retrieval of organs. So donation after cardiac death in our country. The first attempt was made in 1994 in Ahmedabad. They did first kidney after cardiac death. For some reasons, it didn't work for a long time. Very short time it worked. Then patient was back on dialysis. But anyway, for historical reasons, it was in 1994 the first donation which was related to donation after cardiac death. And after that, from 94 to 2011, nothing happened. Then PGI Chandigarh started doing. Till now, we have done about reported cases is about 10 transplants where the donation happened after cardiac death. Only 10. But anyway, so some awareness is there, something is moving in good direction. Donation after brain death. There was a survey 2 years back. As per that survey, it was done by the neutral party, not by the doctors. Every year, we lose about 5 lakh patients. Every year, 5 lakh patients just waiting for organs. They have done the registration, they're just waiting for the organs. Maybe with the dialysis patient is going for dialysis, waiting for the organs. So roughly, it looks like it is an underestimated number. The actual number will be much higher than 5 lakhs per year. I'm very sure that there's no doubt on that. It is underestimated number that 5 lakh patients die just waiting for donation or just waiting for organs because they don't have donors. They can't go for unrelated transplant. If it is a cardiac transplant, fellow has to wait for a brain death because there is no question of live donor there. Maybe in kidney that advantage is there. You can go for an unrelated transplant, but good number of patients who are from low middle class or low class cannot afford to go for an unrelated transplant in our country. The cost is very high. The hospitals will charge more, and the recipient they have to pay money to the donor also. A lot of legal hurdles. So much of troubles there. If you really want to go for a transplant, the patient won't be able to afford unless they have a lot of money with them. Otherwise, they just die or they just try to continue dialysis as long as possible. One brain dead person can save up to 8 lives, 8 persons, and can help up to 50 patients. One brain dead person, if they really want to proceed, he can save up to 8 persons' life and can help up to 50 patients. So which are the organs we can take? We can take heart, we can take liver, we can take both the lungs and give to 2 patients. We can take both the kidneys, give to 2 patients. Pancreas and intestines. A few centers, they go for intestine transplant also. Even in India, intestinal transplantation started now. So anyway, the first few transplants regularly done. Recent past, there are case reports of intestinal transplantations also. So these are the various organs the brain dead person can donate. Next slide. So what are the tissues? I said organs. There are a lot of other donations can, no, in the form of tissues. It can be cornea, skin, tendons, cartilages, heart walls, and bones. These are the other tissues we use after the brain death. No, if somebody is willing to donate, all these things can be used for different patients. Why this? See, there is a big need for organs. There is some kind of awareness in the society, even in the government level, there is awareness. It's not that they're not trying, but still, why this program is not very successful now? Need is big, but what is happening is only very small percentage of donation happening because of brain death. There are different problems at different levels. The legal problems, hospital related problems, community related problems. There are problems in the community. I'll tell you what are those problems, and the problems at the government level. If you see legal level, as Gopal said, there is no need to go for a two declarations. See, a brain dead person, the time is very crucial there. You declare brain death, then you wait for 6 hours. If something happens, if cardiac activity stop, he's out. And we know that the second declaration is not required. And most of the countries, they don't insist on the second declaration. By doing this, actually, we are losing, first of all, very few patients agree to donate. After that, there are a lot of other issues like this. No, the patient will say that, okay, we would like to proceed with the donation. But then problem of first donation, that first diagnosis, that itself will take time. Then we have to go for a second diagnosis. That will take another 6 hours. After that, some more time. A good number of times we lose patient because heart has stopped working in that time. So we lost that whole process is wasted there actually. So there are a lot of legal issues. That the government, for some reasons, maybe for a good reasons, they are very defensive. They don't want to get any name saying that actually that person was not dead, but as for the medico-legal criteria, it was declared dead and taken organs. Government is going more defensive than us. So these were the reasons. Legal issues. There are a lot of legal issues. I am just naming one or two. These things are not very familiar, not very successful. In fact, I'll tell you that there was one incident, Dr. Prakash must be remembering. Few years back, there was one cadaver transplant happened in Lucknow. The team of doctors said he's brain dead. After 6 hours, one more declaration. Everything done. After that, few organs were retrieved. A few fellows got kidney. One other person who got kidney was one VVIP connected politically. So, but that fellow did well. Everything got discharged. After 2-3 weeks, some news came in the media, local media, saying that that person actually was not dead. Just to give kidney to that VVIP person, they declared him brain dead. And in no time, the stones were thrown at hospital. Stones were thrown at doctor's house who declared him brain dead. And government didn't do anything. They just kept quiet. No support was given. And I'll tell you, personal level, a lot of doctors, they're scared to certify brain dead. They say, why I should get involved in this mess? First of all, I have to go in the midnight. Most of the time, this thing happens in the midnight, maybe Saturday night. I have my own family. I am in theater now. They first of all, they don't get anything financially. They won't get anything financially. Or that it is unwanted, unnecessary commitment, which is not recognized by anybody. Nobody will tell Dr. Das came at 2 o'clock in the night, saw a patient, declared brain dead. Then once again he came at 8 o'clock, he declared once again. Nobody. It is all totally unrecognized. Only God has to recognize. Otherwise, management doesn't recognize. Patient who got kidney or liver also they don't recognize. It is unrecognized, unthankful job, but it's not supported by the government also. So these are the actual problems why this program is not moving forward. Then there are hospital related problems. So all the hospitals, they don't have the facility to maintain these patients. I'm not sure whether Shifaa is also in a position, because one, they have to take the legal clearance to do this activity. And you should have a very committed manpower to run this program. You should have a transplant coordinator. I can't go and speak to the relatives. Legally, we are not supposed to speak to the cadaver family members. There has to be a system, and you should have an advanced infrastructure to maintain this patient. So a lot of hospitals, even in Bangalore city, may not be able to maintain this patient for such a long time. The whole process will take, we may say that one declaration after 6 hours, one more declaration. It won't happen in 6 hours or one day. The whole process goes 2 to 3 days. Till that time, you have to maintain this patient on artificial support. Unless you have a very good infrastructure, committed ICU team, they just die. Most of the time, they die without anything. So there are some hospital-related issues. Then there is a community-related issues. See, there's a lot of time, some kind of a unawareness, I don't know what to say, some myths. No, if I give my donor, I'm an incomplete person for a next gen, or I've seen my own religious fellow saying that nahi wo haram hai, aisa nahi karna hai, aisa nahi karna hai. A lot of myths. I personally have tried to speak to few probable donors, which I'm not supposed to do. But patients were coming to me to take opinion about the patient. Then when I told them, see, these are the possibilities. So very aggressively they said, "Yo haram ka kaam hai, aisa nahi karna hai, wahi karna." It's basically unawareness about the donation. I'm not saying it's seen in all the communities. It's not Muslim or Hindu or Christian community. There is some kind of a fear in the community. By doing this, I'm going against the God's wishes. So I won't go more detail into that. There are different level of issues there. And there is a government issues. Government is not in a position to fund this kind of activity. See, if you really want to run this program well, there has to be a financial support from the government. See, I'll give one example. If imagine this Shifaa hospital want to convert one brain dead person for a potential organ donation. So they have to maintain this patient for 2-3 days. The whole process will take average 3 days. During that time, there will be a lot of expenditure. Vasopressor, inotrope supports, patient needs ventilatory support, patient, a lot of, whatever it may be. There is a cost involved in that. We cannot ask donor family to give that money. Can we ask? It is not possible. We should not ask. But at the same time, hospital also has to run. This is the place where I feel the government should support. Okay, if there is a potential donor, if you try also, it's not only that it has to be successful. You started initiative, it has to be successful, then only we'll pay. No. If somebody is attempted to do this, whatever the expenditure is there, it has to be taken care by somebody. Hospital cannot take care actually. So these are the various troubles, various problems, ground level problems, why this program is not increasing. Because if you take our own state, there are so many potential donors, brain dead donors, potentially. The 100% sure that it can be converted into a donation, but nothing happens because the various level problems are there. So very sad, but it is the truth right now what is happening actually. So many patients. I'm telling you, he is one of the patients. So he's lucky that he survived. There are so many patients waiting, and one day they stop coming to dialysis. Then after a few days, we realized that he died in a local hospital or he died overnight at home only. So this is the scene of waiting list in our state. This is as per yesterday's numbers, yesterday's list. I spoke to in charge person yesterday. See, there are uh, waiting lists for liver, kidney, heart, lungs. So if it is a waiting list in the A blood group for liver, 340 patients are waiting. The A blood group, only in the A blood group, 340 patients are waiting. The total, though if you put all the blood groups, there are about 1,378 patients waiting for liver. If you see the kidney, the numbers are much higher, almost 4,700 patients are waiting on list for waiting for the organs. So if you see the heart, these fellows are in a very bad shape. They know that they will die today, tomorrow. At least for a kidney patient, we can do dialysis. They can prolong their life. But in heart, patient with a congestive, dilated cardiomyopathy with the ejection fraction of 15 or 20%, who can't stand also, can't walk one step, he'll be just hoping that I'll get a heart. Because he can't go for a dialysis. There is nothing like a heart failure patient where we can give dialysis or some other treatment so that he gets some symptomatic relief. We can prolong his life. No, he's just hoping that today I'll get. Like that, the patients will go. So if you see the heart, there are 36 patients in A group. There is about 43 patients in O blood group and about 133 patients right now. Yesterday's, as for yesterday's numbers, there's about 133 patients waiting for the heart. And these are very unlucky patients because they can't pay and get heart also. They depend only on brain death related donations. So, yeah, about a lot of patients still waiting. So what is happening right now? Last year, if you take, there is only 150 donation happened. 150 patients, brain dead persons donate the donated organs. So numbers are very small. The need is much, much, much bigger than what it is happening down. Yeah, in short, this is my last slide. In short, there is a big need for organs. It's not only the kidney, every organ, liver, heart, lungs. Big need, big numbers. The waiting period is unimaginably high. 6 years, 7 years only for the kidney. It is very, very, average lifespan for a dialysis patient in our country is about 5 years. If it is a non-diabetic. If it is a diabetic, then about 2 years. Where he'll wait for 6, 7 years? No. If he wants to wait also, no, he won't be there. So waiting period is unreasonably high or very prolonged. Solution is there. I'm telling you, there are a lot of potential brain death donations can happen in our state. Forget about the country. I'll tell you in my own hospital, such a big hospital. Every year we are just able to convert 2 or 3 donations. Ours is supposed to be the biggest hospital in the, maybe one of the biggest in the country, maybe the biggest in the state, where we have about 300 ICUs. No, all ICUs put together, like adult ICU, pediatric, neonatal, adult surgical ICU, adult medical ICU. So about 300 trauma ICU, about 300 dialysis, 300 ICU beds are there, and good number of time it is full, almost near full. I'll say about 90%. But what is the conversion? 1 or 2 per year. We are there. We are putting our own. Legally, we are not supposed to go and speak to, but unofficially, we still go and speak to them sometimes. Because if they come to us, because we will be seeing that patient, we will try to tell them, or we will tell our coordinator to go and speak to them. Still, the numbers need is there. There is a solution, but nothing is moving. That's all. If you have any questions, I'll try to answer. Otherwise, we'll proceed.
regarding this registration, possibly I don't think actually they have all register. All the patients who need transplantation, do they register?
The policy now is if for the kidney, patient has to be on dialysis at least for 2 months. Sir. After that, we have to certify, the team has to certify that he is medically fit to go for a transplant. Then only the registration happen. If I say that this patient is on dialysis for 2 months, I have to certify that. And I will say this patient has been evaluated for kidney transplant. He is found medically fit for transplant. Then nobody can deny that. He'll get registered. He has to pay only nominal fees of 3,000 rupees. Just very nominal fees of 3,000 rupees, registration done, and very, even though it is a government, see, we are not in a position to allot the kidney, whom to allot. It is by the government committee, that is what we call SOTO or Jivana Sarthakatam. They're doing excellent work, sir. Normally what we feel, oh, it is a government agency, okay, I know Idiyarappa, so let me see what. Nothing will happen. Trust me, nothing will happen. But every patient will say that I know Modi, I know Modi's Prime Minister office person, I know him, I know them. Nothing happens. One of the very fair department which is run by the government. 100% I will say there is no hanky-panky there. I know, everybody knows how the government system works. You pay money, you are influential, your name will come front. No, nothing will happen. It is very transparent system. There is no question of somebody is below coming up. That 100% I'll say that last 22 years of experience in this field, I'll say not in the one patient I've seen anybody getting, because he is related to Shiv Kumar or whoever it may be. No, nothing happens. I'm telling you, the persons who have direct connection with Prime Minister office, they'll say, when initially their patients are, no, Martin is a registrar, I know Prime Minister office, sir, I register Madi first, but after a few months, they'll realize that trying all this, they try they're desperate. I think maybe it is, maybe they're right in trying all those second, outer ring methods to get kidney. But I'll tell you, sir, nothing will happen. It is very fair, even though it is controlled by the government.
Sir, as I told is right. Very less registration. See how many patients are on dialysis. Only 5,000 are registered. Because we fail in counseling. So I don't know. Even the one thing what I'm facing difficulty is counseling the patient for early AVF. Patient will not get AVF done until they come to ICU. Second thing, registration. I tell you, say I'm a government employee. I told everything is free. This one, your transplantation is free. Drugs are free for your lifelong. Still, there is a lack.
No, that
I don't know. We'll see. People will not agree, especially when they come early. No, if the guy is 20 years, all will come. All whole family will come. That time they are very keen and they will register. If they wait for another 6 months, no, this one will go. Interest will go. Registration is very less. Otherwise, even donor also less and recipient also less. Actually, you could have more. Actually,
no, the numbers are underestimated. Only small fraction goes for, and good number of them, they don't have money. They feel that okay, let it go as many days as possible on dialysis. I don't have money because even after transplant, good number of time, you have to spend about 10 to 12,000 rupees every month for a immunosuppressive medications. Provided God is grateful for him without any complications. If there is any infection, we treat them aggressively. No, we hit them, start with only meropenem. We won't go step by step. There's nothing like step by step in a transplant patient. Patient comes with the infection, even before sending investigations, he's on meropenem, high-end antibiotic, the antifungals, the newer antifungals, very expensive. I'm telling you, if everything is smooth, absolutely fine, no issues, still he has to pay about 12 to maybe depending on the weight. If he's well built, he has to pay more because the need for a dosage will be higher. So somewhere between 10 to 15,000 for a very stable patient. So that's the reason patient thinks कहाँ से लेके आऊँ इतना पैसा अभी भी देना है बाद में भी देना है रहने दो कितना दिन जाता है dialysis में जाने दो. That is the attitude for most of our patients. I'm not saying See, this is problem is there, and it is badly hitting the middle class. The upper class, somewhere they will go. Who can crook? They'll get unrelated legally, pay heavy money, or they may go out of the country. Do it. It's not illegal. It's legally unrelated can be done. The problem, the poorest poor, they don't go for dialysis also. They just die. The problem is lower and middle class families where they can't. They know that there is a treatment. They know that they can spend some money, but not in a position to go for a complete treatment.
Can it be done before dying? A person declared by donate the kidney to person who is in need.
No, right now that option is not there, sir. I'm telling you that is good actually. That option should not be there. Now, right now, government decides. I don't have any, even though I would have taken care of the patient for a long time, I don't have any role on that. I think it's a good system. Let it go to the government and let the government decide. The moment you do that, there are a lot of other things will come. The initial intention may be good, but over a period of time, you are in a bigger mess actually. I hope that I answered your question.
One more is actually in case if you retrieve a kidney from any setup which you are donating, right? So one kidney goes to the hospital, one kidney goes to the pool. So if that actually kidney you are allowed.
No, sir.
Even that is not allowed.
Now it's changed.
So it is now what is happening is if one Narayana hospital has converted one brain dead person to donation, normally what used to happen, one kidney is to go to the pool, other kidney will go to NH. But I'm not in a position to select patient. There also in NH waiting list, who's there, they will give. If the registration is not there, then it will go to other. Last minute, somebody can come say that, say, I'm from NH, I'm getting dialysis, give to me. No. If there is no registered patient in that blood group, it goes to other hospital or it goes to the common pool. Doctors know where it is a very good system because I have attachment with my own patients. A lot of patients who are on dialysis 8-10 years. I am not in a position. Very fair system, even though it is a government system.
Only registration. Even I tell them a patient, even if Modi comes, he has to register.
No. We keep hearing that story. Sir, my brother is with Ediyarappa for 20 years. My uncle is working in Prime Minister office. I said, okay, good. If you get it, is good, but difficult. No, sir. Now we Marthi, sir. Then after 6 months, they won't look at our face. They know that they can't do anything. It's a very good system. So there's one. The general tendency when we say that Jivana Sardhakate allots, they say, okay, we can do something. But it is, I'm telling you, last 20 years here, no, it is not possible. It is a very good system, whatever it may be. Whichever, whoever have done that.
For every potential kidneys, they will call 5 people. One kidney, 5 people. They send for transplant. If the first one transplant become positive, it goes to the second person. Any other, like that. It's a full general.
The allotment is very fair, very reasonable, very transparent. I have not seen anybody, anybody can raise questions also. Thank you, sir.
I take this opportunity to thank Dr. Ishtiaq. Wonderful, lucid presentation, very practical, and Sridhar and Prakash. I think fitting for this first session is in case of us can decide that we are going to donate our organs, not that we have a cup of tea. Yeah, it's possibility to start from actually charity should start from home. And start to work on this because in case that happens, automatically actually it is going to be a big success. All these legal hurdles, blah blah blah, all can be taken care of. I need to promote this, as Gopal said. Actually, we are not convinced. Yeah. So not actually in case if we can take up this cause and the priority and ultimately a good cause, yeah, this SCACM is going to be a big roaring success across India. So with this, actually, it is I will adjourn for about 10 minutes, have a cup of tea and come back. Thank you. We all get up in the morning, right? With lot of opportunities. The key people are those who are going to capitalize on this and ultimately convert these opportunities for making their hereafter. Very few people do that. People that convert that into money, which should not be the attitude. But the biggest problem what we are facing today is there's so many people who don't get up with opportunities, they get up with challenges. So they are the most lucky because they need to convert challenges into opportunities and capitalize on them. So possibly we can do a big job, especially to help this unfortunate ailing community where actually they are unfortunately suffering because of lack of kidneys. Right. So I'm extremely grateful. At least awareness is created among we physicians and doctors of different departments because there are a lot of hitches. In fact, Dr. Rekha was discussing with Dr. Prakash regarding donation, about actually permission, so and so forth. That so many hitches, but always actually anything that is good, always actually roses taking care because of thorns. Yeah, that we need to remember. So we should not give up. Yeah, stick to that, and we're going to make sure there's going to be a successful program. At least we can start retrieval in Shifaa. Yeah, donor over time. Yeah. So basically for that, there's some legal actually clearances we need to take. We'll start from day one from today that we can do it. But basically how to go about a dedicated team. Yeah, it may boomerang and ultimately it may actually be as a double sword. Prakash gave actually a scary picture to me now when you're sitting separately. Oh, it is not so easy. It is actually a different world. Well, so I actually now Prakash actually had already a program beforehand. He told me the other day. So he's going to actually go to a different place where he's supposed to possibly address or he is a panel member there. So I told him just to attend the first session and take leave. So a pleasant actually job I need to do is to offer him a memento so that he comes back. Yeah. So I request actually Prakash to come here, and I request Dr. Rekha to hand over a memento to him. Yeah.
Please come. Where is Mushtaq now?
As usual, busy. Incidentally, actually, two of my friends, they have come from States, one from UK. We met in Bangalore Club last night. Yeah. So, fair enough. Actually, at least we can send this. At least both, he was absent there. So, he's trying to make up that absence.
Yes, absolutely.
Actually, had other childhood friends had come to him, it seems. So, he was also. Thank you, Prakasha. Dr. Sridhar, well, actually, still patients are waiting for him upstairs. He starts his day. He has actually shifted his house to Kengeri. Yeah. So all the way, once he leaves the place, he goes back in the night. Comes to actually Victoria. There he's there the whole day. Sees actually hits a century there. That is what the number of the patients he sees. I don't know how he sees that number there. Ultimately, then with the same patients, what we see him in the morning, he is patient enough to see the patients here. Yeah, invariably the patients, actually they worked up in the evening waiting. And he goes to Mallige, he comes here. That endurance, we see very few people. And again, has some function to attend. Thank you, Sridhar, for coming. And I request actually, Dr. Naseem is here. Acha. Dr. Zia, can you hand over a memento to Dr. Sridhar? Zia is our anesthetist here. Thank you. I think so. Gopal and Dr. Ishtiaq are going to stay for some more time. Yeah, till Ishtiaq is there. So we'll actually put it for the second session. Now I request Dr. Yusuf. Yeah, to actually chair the session, please. He used to be the young actually nephrologist. He's done his DM from in nephrology from Ramaya. Presently, he's looking after setup of Ramaya in it is Harsha Ramaya, right? Yeah, very reading, and he comes to the main Ramaya too. Please take a seat. So, and I thought actually Dr. Actually Naseem, so he is also unfortunately is left for the day. I request Dr. Zahid to take over as the second co-chair. Yeah. Over to our chair for carrying out the second session.
Good afternoon, everyone. I think it's good afternoon. I think we've heard in detail about the organ procurement and logistics involved in detail by Dr. Ishtiaq sir. Now we have Dr. Akhil, who happens to be my senior in Bangalore Medical College, to discuss about the organ donation after controlled circulatory death. Over to Dr. Akhil.
Good morning, everybody. Assalamu alaikum. Alhamdulillah, this session, more than a CME, it's like we have gathered here for a social cause. Dr. D.K. Prakash, he was one of our teachers, and Dr. Sridhar, he was our senior in BMC. I would like to thank all of them also, and whoever has joined here, and many friends. Dr. Shoaib has joined from Hyderabad, and other people from AMU also. Some people have joined live to attend this session. This session is not about just an academic session where we are going to enrich our knowledge. We know, understand what is happening in the renal field, how transplants are happening. No, this is more like a social cause. We are gathered here for a social cause. You have just heard the numbers, what is happening, what is the scenario. People in some of the blood groups, the waiting list is as long as 1,800, 1,900. And if only 150 transplants happen in a year, so a person who has registered now will get a chance to have the kidney after 10 years. So it's like 1,000-day rule in what people are waiting to get a US visa. Just to get an interview, whether you get it or not is different. Just to get an interview, you have to wait for 1,000 years, 1,000 days, 3 years time. So it's like that. So this is probably, I would like to thank Dr. Ishtiaq Saab. He has taken this initiative to increase the awareness among the people so that the organ donations happen. And this problem of people is not donating organs is not only faced by India. The whole Asian scenario is something similar. The same issues have been faced by people in China, by people in Korea. Now, of late, they have brought in laws which are helping them to gather or to gain more organs for their donation programs. But otherwise, the scenario is similar across the Asian countries. Yes, of course, in Spain, and since they have made some laws that you have to donate your organs, that organ donation rates are higher. The other important point about this is you need to have that infrastructure. See, 15 years, 20 years before, when we were in BMC, when we were doing internship, only 4 dialysis machines were there in the government hospital. And the amount of people who were reading dialysis, forget about transplant, people were not able to get dialysis. We had lost a patient who was, 17-year-old, and all he had to get was some good dialysis. And since there were only 4 machines, we could not dialyze him and he died. So the scenario has improved. We are now able to talk about transplantation, but the infrastructure to give this a push to make this transplantation, especially even if you say brain death, the infrastructure which is required is really should be of top class to have some meaningful outcomes. Otherwise, what happens is each patient who has a failed donation, a failed transplantation, he will end up being the roadblock for all 10 other transplantation patients. If you see the dialysis unit, the one person who has got a failed transplant, people will look at him. There were discussion like people are not registering. They will see that one person who has lost his money, who has lost his this thing, he's back on dialysis. He will be the stumbling block for all other patients. So the need for infrastructure has to improve. The awareness has to improve. So we have gathered here not just to enrich ourselves, but as a social cause, I believe. Okay. With this, I would like to start my presentation. Organ donation after brain death followed by circulatory death. This is an old pattern. Now it has been adopted in China. I would like to speak about it. Some historical aspects, the 1,000-year-old dream of man to replace damaged or underdeveloped organs with healthy ones, it became a reality in the 20th century. Emmerich Ullmann in Vienna, Austria, performed the first successful kidney auto-transplantation. This was done in a canine model dog in 1902. He also performed allotransplantation between dogs and xenotransplantation. The first attempts for human-to-human organ transplantation happened in 1930 in today's Ukraine. Oh, sorry. The first attempt to human organ transplantation happened in 1930s in today's Ukraine. Between 1933 and 1939, Yuri Uronov performed 6 kidney transplantations with the goal to bridge kidney function for temporarily non-function in toxic cases. These were all only for short time, just for the recovery of the renal function, where they did the transplant. He used the kidneys of recently deceased donors. Today, what we call the donation after cardiac death, for a long time it was termed as non-beating donation. The real breakthrough came by Dr. Joseph Murray in 1954 with the long-term successful renal transplantation between identical twins. These were the days when the immunosuppression protocols were not matured enough, were not there. So there were no, people had difficulty in transplanting patients. So since the identical twins, they require very minimal immunosuppression, he was able to do it. And this event gave a boost to the use of living donors and non-beating heart. And after this, the non-beating heart donors had a difficult time because the success rate of living donors was proved. Okay, okay. Brain death and cardiovascular death. Sir has extensively, Dr. Gopal sir has spoken extensively about brain death and Dr. Ishaq sir had touched upon the cardiovascular death. The abbreviation DBD means after brain death. This definition came just after the technical development, which made possible to maintain circulation and breathing of intensive care unit patients who had an irreversible damage to their brain. The technical development made necessary to distinguish between cardiovascular death, meaning a pulseless patient. Cardiovascular death, we all know, it's a pulseless patient. Patient has lost all his cardiac activity. This was the earlier definition of death. Then came this neurological death, meaning an artificially sustained cardiorespiratory system in case of irreversible brain damage. In 1963, first in the world, Brussels, the kidneys of brain dead donors were transplanted. So the first brain dead donation happened in 1963. So coming to the Maastricht classification, developed at Maastricht in Netherlands in 1995 during the first international workshop on non-beating heart donors. So DCD was called as non-beating heart donors during those days. So we had 4 types, and type 5 was added in 2000. So the type 1, sorry, back. So the type 1, death on arrival, irreversible cardiac arrest on the street. Somebody who is arrested outside a hospital setting. So this patient, so type 1, we only transplant the tissues from these organs, like we have the sclera, the cardiac valves, the skin. These are the organs which are retrieved from a type 1 individual. From the type 2, we have unsuccessful resuscitation. This includes patients brought into the emergency room while being resuscitated by the ambulance crew. So the patient is dead on arrival. He's been when he comes to the hospital, he's been resuscitated. He's not yet declared dead. Type 3 is imminent cardiac arrest in intensive care ventilator in an intensive care setting. So most of the DCD donors, what we are talking today, which are happening in Spain, which are happening in the UK. UK has a very robust living versus cadaver program. It has almost 50% of living and cadaver program. This is what they are talking about. Imminent cardiac arrest in intensive care setting. In this setting, the patient is not brain dead. The patient is alive, but he has a medical condition which cannot be reversed. He has a medical condition which cannot be reversed. His clinical outcome is bad. So what they call as withdrawal of life support therapy. So patient is on a life support therapy. There are no, the prognosis is very bad. Probably patient has suffered some hypoxic injury to the brain. He's in a irretrievable vegetable state. So this kind of a patient, they withdraw the support. So this is called as imminent cardiac arrest in an intensive care setting, and they label this as the controlled cardiac death, controlled donation. And we have the type 4, what we extensively we spoke about the since morning. It's the type 4 where we have the cardiac arrest during or after the brain death. And then there is a type 5 which was added. It is an unexpected cardiac arrest in an intensive care setting. So we have these 5 types of donors. Nearly 2 decades later, when DCD donation became widely routine in Western countries, the Paris Consensus, that's what Ishaq sir was referring to, modified the original Maastricht categories based on the location and whether the procedure is controlled or uncontrolled in logistics. So usually they call type 3 as controlled, where we withdraw the life support in an ICU setting or in the OT, and the uncontrolled is the other categories of donation. Sometimes type 4 is also called as controlled. Type 3 category was called controlled, rest of them as uncontrolled. Next. So the Indian perspective, in India, there is a significant lack of awareness about end of life care, palliative care. withdrawal of life support therapy, and a general understanding of organ donation and its altruistic value to the society. This awareness is lacking. This forces the majority of families to demand discharge, or they transfer against medical advice. This often results in the death of the patient during transportation at home, because we remove the life supports, we send them home. Either they are intubated just on a room air, or they are extubated in the ambulance and we send them home. So the patient dies in the ambulance or they die at home, amounting to we are actually withdrawing the life support without organ donation. So this we need to change. The seminars like this might be a means to change this scenario. A similar dilemma exists in brain dead patients whose families do not wish to donate organs. Some of the landmarks in transplantation, sorry, I think the print is very small. So 1994 was the Transplantation of Human Organs Act passed by the Indian Parliament. 1995, the Transplantation of Human Organ Act rules were published. 1999, that was the one IKDRC they were referring to earlier, that the first diseased cadaver kidney transplantation was performed in Ahmedabad. 2011, after almost 10 years, the first DCD was performed in PGI Chandigarh. Then 2011, Transplantation of Human Act was passed, and 2011 there was a case, Supreme Court judgment on Aruna Shanbag case. In this, they mentioned that an incompetent person, parents, spouse, other close relatives, or next friend were allowed to withdraw nutrition, water, or withhold life support therapy with court's approval. Withdrawal of cardiorespiratory support in brain dead was also brought out. So 2011, they said you can withdraw the life support in brain dead individuals. Then TOTA rules were published in 2014. Then end of life care guidelines were published in 2014, 2015. Then summits were conducted in 2015. Then 2017, the first liver transplantation was done in a diseased cadaver donor in Delhi. Then 2017, the Supreme Court ruled in Justice Puttaswamy case that the right to privacy included the right to refuse life-sustaining therapy. I can refuse life-sustaining therapy. They said this is a part of the right to privacy. Then IOC guidelines were published. Then in 2017, first national symposium. Next. First national symposium on death and dying held in Mathura. The Mathura Declaration was formed. In this, universal concern for improving end-of-life care in India, citizens' action needed for dying in dignity, and intersection of universal definition of death, UOCL and WLST were discussed. Next. Federation of FICCI and End-of-Life Care in India Task Force published a guideline to improve end-of-life care. And then 2020, this came about that initially we were all afraid during our internship days and all, do not resuscitate, this was not there. Now this column has come, do not attempt resuscitation consensus guidelines were published, and then guidelines for end-of-life care have been published. So we need to go about all this. Our eminent resource persons, they were telling that still the guidelines are not very clear about all this. So we need to go dig into these guidelines and figure out what we can advise our patients and what we cannot. So now I would like to discuss a scenario from China. So although kidney donation after brain death is considered a standard donation strategy. This is what is we are also adopting and has been established in Western countries. There are many obstacles preventing acceptance of Harvard criteria of brain death. See, we had difficulty in accepting that patient can have spinal reflexes. Patient can have other this thing. So the laymen are not aware. They might be thinking that, okay, he is making a recovery. Now his hands are moving. Probably tomorrow he will get up and talk. So these are the things which people are not ready to accept, especially in young donors. And all the organ donations, we need the organs from the young donors. So in some cases, in countries like China and Japan, so they have what they have done in the light of cultural barriers, efforts to promote DBD in China have not been satisfactory from 2009 onwards. They have not succeeded in this. So once what they have done is a novel donation concept, namely organ donation after brain death by circulatory death was officially initiated in 2011, which could be regarded as a combination of recognizing brain death and circulatory death. So you have both brain death and circulatory death. A multi-center, I would like to speak about a paper. It's a multi-center retrospective observational cohort study which involved 523 kidney transplants from donation after brain and cardiac death, and it includes both the patients. So there were 383 who were brain and cardiac death and 140 who were only brain dead individuals. So we would like to see what is the what were the complications which were anticipated in these two people. So the definition of brain death was in this study. The definition, sorry, back. The definition of brain death was strictly determined by the exclusion of confounders, as Dr. Gopal had told us, as well as the presence of three essential findings, namely irreversible coma, absence of spontaneous motor activity, and absence of all brainstem reflexes. To determine the cessation of respiratory function, an apnea test was carried out before the declaration. But now they have simplified the rules that you don't need a neurologist to certify a brain dead individual. Then the cessation of spontaneous respiratory was defined as breathing movement. This is what the actual apnea testing is. So they will oxygenate a patient, and then they will withdraw the ventilatory support, and they will wait for a certain amount of time and see when the PCO2 is equal to or greater than 60, or if there is a rise of 20 mm of PSO2 from the baseline level, whether the patient has any respiratory activity. If the patient has no respiratory activity, even after individual PCO2 is more than 60 or there is a rise of 20 from the baseline, then they declare it as apnea test being positive. Cardiac death. Now, the additional thing what they included in these donors was the cardiac death. Cardiac death was legally defined as irreversible cessation of circulatory function based on definitive proof by confirmatory tests such as ECG, intra-arterial monitoring. They will connect an intra-arterial monitor or a Doppler ultrasound. So after a patient has an asystole, an observation period of 5 minutes was also employed to ensure the irreversibility and permanence of the patient's cardiac death. Oh, I think the print is, this is a schematic diagram wherein the patient is brain dead, then the written consensus, consent is taken from the donors about the organ donation, then the withdrawal of life-sustaining therapy, then circulatory cessation confirmed by monitoring test and declaration of death and organ retrieval. So the post-operative complications, this is what we are interested in, that okay, we are what we are worried about is brain dead individuals organs have a superior quality of life, whether the persons who die after the whether the organs which are transplanted after the cardiac death, whether they also have similar outcomes. So post-operative complications such as incidences of delayed graft function. Delayed graft function, for the purpose of some DNBs, it's a need for dialysis during the first week of post-transplant. If you have a person who is requiring dialysis first week post-transplant, we call that stage as delayed graft function. So then primary non-function, the graft has not functioned after transplant, and acute rejections were retrospectively analyzed. In the paper, they have mentioned there was no significant difference in post-operative complications between the two groups. The p-value was significant. However, there were some 5 primary non-functional grafts in the DBCDs. I don't know why this thing. They had done biopsies of those 5 patients, and they saw that all of them had severe glomerulosclerosis, whether it's FSGS or 5 patients had, but otherwise overall the outcomes were similar in both the groups. You can. So this is the post-operative complications between the two groups. DGF was seen in 19% of patients with DBCD and 22 in DBD. PNF was seen in 5 patients, whereas no PNF was seen in DBD. Acute was seen in 35 of 9% of DBCD and 8.5% in the DBD. So overall, if you can see, the complication, post-operative complications rates were similar between the two groups. The fundamental cause of comparable outcomes lies in controlled warm ischemia time during procurement of DBCD grafts. This is what the main crux of the thing is, why we have similar outcomes in both the groups. In this study, the average warm ischemia time of kidney from DBCD was limited to 16.2 plus or minus 5 minutes, 16 plus or minus 5 minutes. It's almost like 21 minutes, much lower than the average 27 minutes, which was seen in patients who died after cardiac death. This is about when we are withdrawing the support from the patient and then the DCD is not brain dead people. DCD is people where we withdraw the support and then the patient expires. So furthermore, they find higher incidence of DGF and all when the warm ischemia time was more than 18 minutes. In order to limit warm ischemia time, this is a practical aspect which they have underlined. Cardiorespiratory support should be withdrawn in the operating room after all necessary precautions have been completed, and the retrieval team and the operating room staff should be ready in advance. So you need to wheel in the patient to the OR. Better to wheel in the patient into the OR, and then you can. Otherwise, if the transit time between the ICU to the OR is very short, you can do this process in the ICU as well. In conclusion, I think it's not come. I think the other thing is not updated. In conclusion, although DBD is currently standard strategy for organ transplantation, the findings of this study suggest that DBCD is a viable option to provide graft availability to renal transplant patients. In view of large number of people universally who cannot accept DBD, DBCD can be considered a cultural and medical milestone that overcomes donation barriers.
I thank Dr. Rahil for a wonderful, detailed presentation covering all the aspects of donation after circulated death. He also spoke briefly about the historical aspects, about the classification, the Maastricht classification, which is used to classify donors based on the donation after circulated death. I think he has covered almost all the aspects. The floor is open for discussion. If you have any questions, you can take.
Is it legalized and being practiced in India? Question to Dr. Ishtiaq sir.
I would mention that since brain death is legalized, so in this scenario, the patient is brain dead. Even the cardiac death, I think they have, since it's been done in Chandigarh, it's only the logistics which is preventing us from doing it. But DCD is more complicated since the patient is not brain dead. But this scenario is the patient is brain dead. It's only that you are procuring the organ After you withdraw the support system from him, and he suffers an he suffers an ASO. But in this, the only thing is the warm ischemia time is most important. What they say is for the liver, you need the asystole should happen within half an hour. So half an hour for the liver. Kidney, they say 1 hour, sir, I told, but the other articles I mentioned, they have given up to 2 hours because the ischemia, the kidney is able to tolerate ischemia. And the other thing is, patients can be dialyzed after the transplantation till the time the kidney recovers. So there is some option for the kidney. It suffers, it is able to take in more ischemia time. And the second thing, you have an option of dialysis post-transplant till the time that kidney recovers. So we have some this thing. Only I think, but you need to have the logistics in place. You need to have all our cross matches and everything being done at the earlier level. But at least nobody will throw stones at you after DCD.
In brain death, heart is still working, but DCD, there is no legal clearance is required. No committee clearance is required. It is brain dead, cardiac death, that's all. There is no special team is required to certify cardiac death. It's just like any other death declaration. The problem is the logistics. Within a short time, said for liver, if it is anything about 30 minutes, they won't consider liver. Maybe kidney, there are up to 1.5 hours, maybe up to 2 hours, they say that it can be taken.
Sir, what does that controlled withdrawal mean? If the patient is already dead, it is the temperature control or
no,
what exactly does it mean?
Controlled donors are nothing but the death has happened in front of medical team, and the medical team has planned for the organ retrieval. Uncontrolled means it is happening on the roadside, patient died on the roadside. No, by the time he comes, there is. But here controlled is controlled atmosphere for the organ retrieval.
What they do is
the team is ready and to
just waiting. It's like a vulture waiting for a death. No, no, the birds. Some you would have seen on the roadside, dog dying, and one vulture is waiting. Like that, it is. The doctors are just waiting naturally to stop his cardiac activity.
No,
after that they will jump and retrieve the organs. In the practical term, that's what it for a good cause actually.
No, what they say is like your systolic blood pressure is less than 50 and your SpO2 less than 70. It has to come below that, and then slowly the patient slips into asystole. So you are witnessing all that, and then you know what is the warm ischemia time. From the point you withdraw the support, that is the time. No, not the time from you withdraw the support. The point when your BP drops to less than 50, and your SpO2 drops to less than 70. From there, the warm ischemia time starts. So you know at what moment this has happened. This event happened. So in individual, hopefully, most of the thing, the cardiac activity stops within 3 minutes, in timelines. In a DCD, the scenario is different. It might take little bit more because you are withdrawing the younger individuals. They take ischemia more. They will not succumb so easily. If the patient is not brain dead, they might be in a vegetative state, or they might have some irreversible neurological deficits. They might be an accident, whatever is the cause. So they might, their ischemia times may be prolonged. So there you might go for an organ transplantation. You might not. You might lose the organ because you are waiting and the timelines have crossed, and you are not in a position to take those organs.
If no more questions, shall we go on to the next speaker?
Yes, sir. Anything? Not you can add something. I thank the organizers for giving me an opportunity to present this slide. Thank you.
Jazakallah, Dr. Saab. Next speaker is Dr. Mohammed Fahad. He'll talk on artificial kidney, a realistic picture. Dr. Mohammad Fahad is consultant nephrologist at Manipal Hospital, Airport Road.
Hello. I'm sorry if I had 2 minutes. In fact, Dr. Gopal also wants to take leave. Just 2 minutes, Gopal. What I can do is actually even Mallikarjuna also. It is all Latin for you, Allah. So actually, I take this opportunity to thank Dr. Gopal for actually making it today to Shifaa. I would request Dr. Ayah Khan to hand over a memento to him. Please, Gopal. Thanks for coming. We'll be in touch. Oh, sure. And I think so. Actually, we take this opportunity to actually felicitate Dr. Mr. Mallikarjuna. Please come. I request our yours, Dr. Natesh, if I'm not, come please. You can hand over a memento. You're an inspiration for all of us. Yeah, thank you. Wish you a happy life. Welcome. So we'll continue. We have Fahad with us, the youngster. Yeah, who is presently an associate consultant in Manipal with actually a lot of distinctions to his credit. A big actually profile saw about him personal, and he's going to speak for himself.
Thank you, sir. Good afternoon, everyone. Assalamu alaikum to all. I would like to thank Shifaa Hospital and Dr. Altaf to give this opportunity to speak on a relatively dry topic, stem cells and artificial kidney. I would like to thank the previous esteemed speakers, Dr. Gopal, to enlighten us about brain death. Ishtiaq sir, who told us about the current scenario of brain death, and Dr. Akhil, who's enlightened us about donation after cardiac death. So the questions that were answered up till now were, who can we take the kidney from? Can we take from a deceased person? Can we take from a live person? Can we take from a live related person? Can we take from a live near related person? The question I'm trying to answer is, can we make? The answer to that is no. It's a far-fetched reality. We talk about Mona Lisa being a work of art by Da Vinci. I firmly believe that we are the work of art, and whoever we believe has made us has indeed made a very rare specimen. And with all the biomedical engineering, genetic engineering advancements that we are still not able to replicate uh, the organs that we have in this body, the body that we take for granted. On that note, I'm moving on to my talk on stem cells first and then artificial kidney. So this aspect of the talk would cover what are stem cells, what are the classes of stem cells, and where do stem cells come from. It is a little academic and dry, as I mentioned, but please do give some attention. So stem cells are cells which have a unique capacity to produce unaltered daughter cells and have the ability to generate or differentiate into specialized cell types. So their properties would be summarized as self-renewal, differentiation, and ability to form a clonal population. Now, this sheep was famous back in the 1990s. Her name is Dolly, and she was the first mammal to be cloned from a mature cell from a specific body part. So she was made from a cell from the mammary gland of her mother. So technically, Dolly had three mothers. One was the enucleated oocyte from one sheep. One was the sheep who provided the DNA, that is the somatic cell, the nucleus taken from the somatic cell of the mother's mammary gland, and the third mother who cloned the embryo till term. So the production of Dolly showed that a whole mammal can be made from a single cell. And after Dolly's advancement, this is, yeah, second one. So Dolly was made in 1996. In 1998, from University of Wisconsin, James Thompson, a scientist, showed that isolated cells from the inner cell mass of the early embryo can be developed to develop human embryonic stem cell lines. Simultaneously, in John Hopkins, they derived human embryonic germ cells from the fetal gonadal tissue. So the human stem cells can be from three sources primarily. One is yeah, next one. So should I just say next? Okay, next one. Yeah, so the types of stem cells based on their properties and the cells that they can differentiate into would be totipotent stem cells, pluripotent, multipotent, oligopotent, and unipotent stem cells. So totipotent stem cells can form all type of cells, including placental tissue. Pluripotent stem cells can form all types of cells except the placenta. And multipotent, oligopotent, again based on the number of cells that they can form, and unipotent, a single can differentiate into a single type of clone of cells. So summarizing, stem cells would be human embryonic stem cells, somatic adult cells, and induced pluripotent stem cells, which is an exciting concept that I will come to. Next slide, please. So this chart, I don't know if it's visible, but what I want to highlight in this is that the stem cells can be adult or fetal. The embryonal stem cells, are pluripotent, whereas those derived from the fetal or adult stage are primarily multipotent. Ethical problems exist with embryonal stem cells because in the process of extracting the embryonal stem cell, a whole embryo gets destroyed. So that is why there were some certain ethical issues, and hence the need to develop stem cells from or derive stem cells from specific organs, which we will come to. Maldifferentiation is also a problem with embryonic stem cells. Next slide, please. So stem cells can also be derived from the amniotic fluid and placental tissue, and it has been shown and reported in 2007 that the stem cells derived from the amniotic fluid and placental have the ability for extensive self-renewal and can give rise to cells from all the three germ cell layers. Next slide, please. A potential application of AFPS could be delaying the progression of renal tubular fibrosis and progressive glomerulopathy. So one of the antigens that is there in kidney is alpha 5 chain of the type 4 collagen. So the mutation of which is seen in a certain disease that you must have heard of, Alport syndrome. So they had certain mouse models where they genetically engineered them to have the mutation in this collagen 4 alpha 5, and then they injected the amniotic fluid and placental stem cells, and they found that renal recovery was seen in 20% improvement. So with that model, they established that injection of stem cells itself could lead to homing of the stem cells into the injured organ and hence its repair. Next slide, please. So what is induced pluripotent stem cells? So as we mentioned, embryonic stem cells had certain ethical issues, led to the destruction of a whole embryo. Adult and fetal stem cells were also difficult to procure. So they introduced the concept of pluripotent stem cells in 2006, where they saw that somatic cells got reprogrammed and developed into stem cells themselves when kept in an environment which was rich in embryonic transcription factors. Next slide, please. The previous one. So here an adult fibroblast cell, when kept in the presence of embryonic transcription factors, got reprogrammed and became stem cells themselves to lead to the formation of various other type of cells. So this was a breakthrough in the concept of stem cells, where they realized that they could take a mature adult somatic cell and make it into a stem cell and lead to the recovery or repair of certain organs. With respect to kidney, we will come to that. This is search for putative stem cells or precursors within the kidney has been a focus of extensive research. The identification of kidney progenitor stem cells would provide important biological insights, because now the kidney has three compartments. One is glomerular, tubular, and tubular, interstitial, and vascular. They saw that these stem cells could differentiate into all three cell lines, and hence they use that concept into the repair and repair of kidney after certain injuries. Next slide, please. So in the past few years, a number of studies have shown that stem cells can be found in virtually every organ of the body, and the kidney is no exception to that. And there are resident stem cells within the kidney which are located in the papilla and along the tubules. What is interesting is the stem cells which will eventually lead to the production of kidney are not found only in the kidney, they are also found in the bone marrow. And when injected, both resident renal progenitor cells and bone marrow derived stem cells were able to reach the injured renal tissue and help in its repair. Next slide, please. So as we discussed, resident renal progenitor cells are found in the papilla. They express mesenchymal and epithelial antigens. And in the mouse model, once injected under the renal capsule, they were incorporated into the renal parenchyma and tubules. Next slide, please. They were also found in the cortex of the adult human kidney. And these cells differentiated into epithelial cells, endothelial cells, glomerular cells, tubulointerstitial cells, and vascular cells once injected intravenously into the skid mice. So they can be injected directly into the kidney. They can be injected intravenously also. Next slide, please. So as we discussed, the resident renal progenitor cells are available immediately to repair the kidney and therefore are of great help. Next slide, please. So the bone marrow derived renal progenitor cells are able to integrate into the kidney and differentiate into the various renal cell types. There is evidence of engraftment and differentiation of these bone marrow derived stem cells during normal renal cellular turnover as well as during times of injury. Next slide. So they took female mice, they irradiated it, so they have no bone marrow now, and they transplanted the male bone marrow into them. They also induced renal injury into them. And what they found eventually was the renal tissue of this female mice who was irradiated with renal injury now had the male donor Y chromosome, suggesting that the male bone marrow transplant that was done for this female recipient, the cells from there have now migrated to the kidney and are helping with the repair of the kidney and formation of the kidney epithelium. Next slide, please. So another rat model where they took 40 rats. So the kidney was divided into 3 zones. So one side kidney was completely removed. On the other side, 2 parts were removed. So the kidney was left with basically 1 part. So, and they were given either cells, they were given bone marrow cells in the range of 5 million or 25 million bone marrow cells. And next slide. And at the end of 15 weeks, if you can see this triangle, square, and circle, the triangle corresponds to the bone marrow. This the 5 million bone marrow comes here. At the end of 15 weeks, the lowest creatinine was for the 5 into 10 raised power 6 bone marrow, suggestive that once a renal injury is introduced and you do bone marrow transplant or infuse bone marrow cells, the lowest creatinine or renal recovery was seen in those with 5 into 10 raised power 6. However, that didn't apply to those given 25 million cells, which was suggestive that the more number of cells you give, there are various type of cells. This was whole bone marrow transplant that was done. So there were various type of cells and that could have induced a rejection. So you need to get the number of bone marrow cells infused also right. And this also proved the concept that the bone marrow had stem cells which were eventually going to develop into renal tissue or help in the repair of renal injury. Another interesting concept was the c-kit cell population. So not just any stem cell which express the c-kit, which is a marker. It is also a tumor marker used in medical oncology. They found that stem cells which express c-kit and which were induced or injected into patients with ischemic reperfusion injury with this GFP label, they started homing the kidney and started repair of the kidney tissue. So c-kit progenitor cells can regenerate epithelial tubular cells and they can also prevent something called foot process effacement. This term, if you've read nephrotic syndrome, this is one of the pathophysiologies of nephrotic syndrome, that is foot process effacement. The c-kit progenitor cells not only helped in repair, regeneration, but also prevented foot process effacement. They developed into the various renal structures and they mediated or prevented the foot process effacement through the mTOR pathway. Now, another place where stem cells can be used is in the development of something called kidney organoids. Now, we all know that the development of the kidney happens in utero. It begins at the age of 9 weeks, gets completed by 36 weeks. It develops from the mesoderm. It develops from something called the metanephric mesenchyme. And so to understand which genetic mutation would have what effect on what stage of development of the kidney, and what are the effects of the environmental factors on the genetic expression, something called epigenetics, could be understood with stem cells. So stem cells can develop can be used to develop these kidney organoids, which are rudimentary kidneys, and these stem cells would have a certain genetic mutation induced in them. So we would understand what effect of this genetic mutation is happening on the development of the kidney. The stem cell could also be exposed to various degrees of temperature, various oxygen levels, various nutrient supplies, which would mimic the pre-eclamptic state of the mother or the gestational diabetes state of the mother, and hence that would help us understand the epigenetic concept of it. The other source of stem cells, as we discussed, is the embryonic stem cell, where an embryo of 5 days old, the inner cell mass is what is used to extract the embryonic stem cell. They have the ability for self-renewal indefinitely and can differentiate into cells of all the three germ cell layers. So those embryonic stem cells are homed in an environment containing various nutrient factors like retinoic acid, activin A, and given various transcription factors, for example, those produced by the PAX2 gene, Wilms tumor gene, and help us understand the development of the kidney and kidney structures. A major ethical issue with the embryonic stem cell was the whole embryo gets destroyed, as we discussed. And to overcome this limitation, Chung and his colleagues were the first authors to generate mouse embryonic stem cell line, where they could do a single cell embryo biopsy and extract one cell from that inner cell mass and not destroy the whole embryo. The somatic cell nuclear transfer, the concept that was used to make Dolly, as we discussed. So we have an enucleated oocyte into which we put the nucleus of a somatic cell. In case of Dolly, it was a somatic cell from the mammary gland, and then let another mother form that embryo and develop the same. So this is the concept. Somatic cells are taken, the nucleus of that put into an enucleated oocyte, and that then has the properties of a stem cell developing into cells of various germ cell lines. Next slide. So this is a genetically engineered model of a kidney developed from stem cells. So this is a renal unit. This is the urine that is collected. These are the silicone or silastic catheters which are coated with collagen. And this was a renal tissue which was developed from a single stem cell, which eventually developed into this and was producing urine. So they saw that the figure that is marked D is an ELISpot assay of interferon gamma, which comes from T cells and is a marker of rejection. They saw that if they took it from a different species altogether, the ELISpot assay was so well lit. They took it from the same person, that is autologous, the lighting up was not that significant, which was suggestive that rejection is not significant. When they made a renal unit from cloned cells, the ELISpot assay was similar to an autologous, which was suggestive that a renal unit which would be made from cloned cells, either from the patient himself or from another donor itself, would not have a higher risk of rejection as much as a kidney taken from another donor. So transplantation of the metanephros, which is where the kidney comes from, is another interesting and upcoming concept, where they have proposed that transplantation of the metanephros itself with its stem cells developing into a kidney subsequently would be a good concept or a future concept for kidney transplant. The metanephros has decreased immunogenicity because it lacks antigens per se. So that would decrease the requirement for immunosuppression that would be required by the recipient. Next slide, please. And they have done mouse studies or animal studies where the metanephros harvested from embryos was transplanted into the omentum of mice, where they saw it getting vascularized and could exhibit glomerular filtration, and not only filtration, also show the endocrine functions of the kidneys, that is production of vitamin D and erythropoietin. In another animal study, the fetal renal cells that were transplanted into the kidneys into the omentum and abdomen, where had the ability to form mature renal cells having tubular function. Next slide. So the take home message with respect to stem cells would be that stem cells are proposed to help with kidney repair. Stem cells are used to develop kidney organoids, which can help us understand the genetic and epigenetic effects on nephrogenesis. Transplantation of metanephros is showing promising results in animal studies. But as we discussed, it is difficult to replicate what whoever has made us do, and we are a work of art. And with all our advances, this seems to be a far-fetched reality. Coming to the second part of my talk, that is artificial kidney. This triangle or flowchart given by Nissens in one of the leading figures in dialysis, where he said that the goals of renal replacement therapy should be to achieve a good quality of life, to provide good fluid balance, to provide electrolyte and acid-base balance, and to also provide endocrine functions of that the kidney does, primarily being erythropoietin for anemia and vitamin D. So the types of renal replacement therapies, as we have already discussed, renal transplant is a form of renal replacement therapy. William J. Kolff, who was the father of dialysis, in fact called hemodialysis artificial kidney, but I would not be dwelling into hemodialysis per se. The recent advances in artificial kidney is what we will be discussing. So there is hemodialysis, there is hemodiafiltration, which is another form of renal replacement therapy, and then there is peritoneal dialysis, which is done through the abdomen. Next slide, please. So CKD, as we know, is a major cause of death. By 2030, it's going to be the fifth leading cause of non-communicable disease and cause of death. There would be around 14.5 million, yet only 5.4 receive some sort of renal replacement therapy. Renal replacement therapy, as we discussed, doesn't just mean transplant, it also means dialysis, peritoneal dialysis. So the Indian CKD registry in 2012 said that if there are 100 CKD patients who progress to CKD stage 5, only 40% of them would receive any form of renal replacement therapy, out of which 30% would be on dialysis, 2 to 3% would be on peritoneal dialysis, and only 5% are receiving kidney transplant. So the numbers are scary, and it also shows the shortage of donor kidneys that are available for transplantation. Now, dialysis, however good your RO water is, however good your dialyzer is, it is still not a natural process. We are trying to replicate 24/7 renal or glomerular filtration for 168 hours that is done through the week with 3 sessions, or some patients even ask for discount and say we'll try to do 2 sessions of dialysis. So 8 by 168, it's not even 5% of what the human body already does. So the kidneys, apart from just removing water from the body and providing good potassium or good bicarbonate and maintaining acid base, also has endocrine functions and metabolic functions. The dialysis that we do based on the dialyzer removes only some amount of uremic solutes. Uremic solutes are not just the BUN and the creatinine that you see in the renal panel. There are more than 100 uremic toxins ranging from small molecules to larger molecules. And what we achieve in dialysis is primarily the small molecules. What we achieve through the hemodiafiltration, the more advanced form of dialysis, is some amount of middle molecular clearance. But still, we are not able to do what the human natural, what the kidneys do. Also, we remove, in general, we pass what, 1.5 to 2 liters of urine every day. During a dialysis session, we try or attempt to remove 3 liters, 4 liters from the human body, which is a massive fluid shift. It can cause a stunned myocardium, lead to hypotension, and even neurological effects for the patient. So definitely the need to develop an artificial kidney, which is working more 24/7 and provides a clearance close to the human kidney, was attempted. However, they still do not provide a clearance remotely close to what the body does. So an ideal artificial kidney should have a small size. We should be able to wear it, or it should be implantable within the body. It should have a vascular access which is needleless. Now, all our dialysis patients, you must have seen them having fistulas where needles are placed. The needles could get dislodged, or they have perm cats which have problems of thrombosis and obstruction associated with them. So the vascular access of an artificial kidney should be free of these complications. Now, dialyzer membrane, however compatible it is made, it is still a foreign structure, and when blood interacts with it, it leads to the activation of various immunological and non-immunological pathways in the body, one of them being something called complement pathways. Now, the dialyzer membrane that is used in the artificial kidney should be biocompatible. Uh, Integration of convective dialysis therapies. Now, the hemodialysis that we generally do is based on the concept of diffusive clearance. That is a dialysate which has a lower or no urea, basically the blood which has high urea, it would diffuse from an area of high concentration gradient to a low concentration gradient. It should also incorporate something called convective dialysis, which is based on the concept of solvent drag. That is, you move fluid from the patient's body into the other compartment, and with the water will move other solutes, that is the middle molecules that are there in our body, something like phosphate, FGF23, and that would improve the clearance. So the artificial kidney should incorporate that too. The blood pump should be quiet in the artificial kidney, which would be variable, implantable. It should ideally work on the flow generated by the pumping action of the heart. The dialyzer fluid, so what we do in dialysis is the dialysate flow is 500 ml per minute, which is 30 liters per hour. 4-hour session would use 120 liters. So the wearable artificial kidney should not use that much amount of water. So it should have the ability that once the dialysate has been cleaned, it should be able to regenerate that dialysis fluid or dialysate to be reused again in the circuit. And that was possible because of sorbent technologies, which we will come to. The lifespan of the artificial kidney should be such that it should not require frequent replacement. It should also provide endocrine functions, and hence the new artificial kidneys that are being developed have a refillable depot with erythropoietin. And these artificial kidneys are still out of reach of the middle class man. They are costly, and they should become more affordable. Now, the roadmap of development, where do we stand today? So William J. Kolff came up with the concept of hemodialysis, which moved to home hemodialysis. Then came the first generation portable artificial kidney, which was weighing 10 to 25 kgs. Then came the second generation, which was between or less than 10 kgs. Then the wearable artificial kidney was less than 1.5 kgs. Now the implantable bio-artificial kidney, which is like 500 grams. So sorbent technology, which we discussed, help regenerate the dialysate. Conventional hemodialysis, as we discussed, uses so much fluid. The sorbent technology basically requires 6 liters of potable water. And with sorbent dialysis, the spent dialysis, that is the dialysis fluid after it has cleaned up from the patient, should be regenerated. It doesn't require a water supply. It can be used patient bedside. It can be used in remote locations. However, the problem being that it is not ambulatory and it requires activated carbon. So a sorbent has 6 layers. One is the layer of activated carbon, which binds to heavy metals and helps to remove various other toxic waste. It has a layer of urease, which converts urea to ammonium and bicarbonate. Another layer of activated carbon to bind to more waste products. A cation and anion exchanger, which will eventually release H plus and OH minus, and a final layer with bicarbonate. So as the used dialysate that has come off from the patient, it moves into the sorbent layer and comes out regenerated. This would be followed by an enrichment module, which we will discuss later. Next slide. So artificial kidneys are divided into automated wearable artificial kidney, which is based on the concept of peritoneal dialysis, wearable artificial kidney, which is based on the concept of hemodialysis, and implantable artificial kidney, which is now biomedically engineered. Now, miniature devices for hemodialysis are the wearable artificial kidney, 5 kgs, the Neo Kidney, Easy Dial, Medtronic, and Fresenius. If you see, none of them are in human trials. Most of them, only the Neo Kidney portable artificial kidney is planned for human clinical trials. So it is a far-fetched reality as of now. Now, automated wearable artificial kidney is based on the concept of using your peritoneum for dialysis. The hemodialysis and hemofiltration, which requires dialyzers or foreign membranes, and require continuous anticoagulation. That limitation is overcome by the AVAC, and because it is relatively it doesn't involve an extracorporeal circulation, it is called bloodless, and since it is reusing the dialysate, it is also called waterless. So the regenerated fluid has the same composition as the peritoneal dialysis fluids that are placed. They contain bicarbonate instead of lactate. The regenerated fluid is recycled back into the peritoneal cavity and also eliminates the protein loss that is associated with peritoneal dialysis. So it has a regeneration rate of 4 liters per hour, providing a dialysate flow of 96 liters per day. And since it is a round the clock dialysis, it eliminates the shocks of abrupt associated with abrupt dialysis. So, next slide, please. So this is a module. So we have a disposable module which needs to be replaced and a non-disposable module which is placed on the person. What is placed on the person is the pump, the cycler, and the battery. This is the peritoneal cavity which would be used for dialysis. Now the disposable module has 4 or 3 bags into it. Now once the fluid has been placed for roughly an hour, it moves into the sorbent cartridge. Sorbent cartridge, as we discussed, which had 6 layers. It gets regenerated, it gets stored, it gets enriched with potassium and glucose, other electrolytes that are required, and is put back into the patient. And the same cycle is repeated continuously until this module has to be replaced, and this has to be replaced roughly 2 to 3 times a day. So this was the disadvantage of the AVAC, that it needed a replacement 2 to 3 times a day. As we discussed, in ideal artificial kidney, it should be something which is long lasting. This was technically not that long lasting. Next slide, please. So the various miniature devices for AVAC or peritoneal dialysis are the CLS, which stands for Carry Life System from Sweden, the AVAC, the WeKid, and the Vicenza variable artificial kidney. They have various different features based on the number of peritoneal dialysis catheters or the lumen that are involved, type of sorbent cartridge that they use. However, I will not dwell into that. But what needs to be understood, that AVAC is one of the artificial kidneys that is available based on the concept of peritoneal dialysis, having 2 modules, one disposable and one non-disposable. Next slide, please. Coming to variable artificial kidney, that is the VAX, which is based on the concept of hemodialysis and hemofiltration. It is light, it is around 1.5 to 5 kgs. It is small enough to be worn as a belt. Next slide, please. So this is how the patient would wear it. So in case of heart failure, we had the LVAD device which had come up, the left ventricular assist device, which was quite similar. It is a wearable thing that the patient wears with the blood, with the battery and operator that the patient carries around with them. The wearable artificial kidney is somewhat similar. Next slide, please. So this is the circuit inside. The red would be the inflow that is coming from the patient. So blood comes from the patient and it moves through the dialyzer and then goes back to the patient after getting cleaned. What is important to note is the dialysate circuit. So as blood moves in a direction parallel or anti-parallel to the dialysate and gets cleaned, the spent dialysate, that is the used dialysate, then moves through this into this area, which is the dialyzer regenerating system, and gets enriched with either bicarbonate and potassium, and is used again to help clean up with the red line, that is the blood incoming impure blood from the patient. And all this would be done in that belt that the patient is wearing. Next slide, please. Coming to the last part, that is the implantable artificial kidney, which was developed by William H. Fessel. It is the biohybrid device which has silicon nanotechnology, in addition with something called BREX, that is the bioartificial renal endothelial cells. So what the implantable artificial kidney uses is, so basically the functional unit of the kidney is the nephron, the glomerulus, which creates a glomerular filtrate, which moves through the proximal tubule, distal tubule, and comes out. What we produce is basically 180 liters of glomerular filtrate per day, which eventually becomes 1 to 2 liters of urine because of the tubular cells which reabsorb majority of the concept. So in case of an implantable artificial kidney, blood moves in, moves through the silicon nanomembrane, producing a glomerular filtrate. That filtrate moves through the cell bioreactor, which contains the bioartificially produced renal epithelial cells, which reabsorb majority of the substance, give rise to urine. So it's an implantable object where its inflow is from the external iliac, venous supply, that is outflow of the blood is through the external iliac, and there is a ureter which moves into the kidney, which moves into the bladder, and that comes out as the urine. So this in its true sense is like an artificial kidney which is implanted into the body, having a vascular supply from the artery and the vein, and having a ureter which is going into the bladder. Its components are the silicon nanomembrane, which has a function similar to the glomerulus, and then a cell bioreactor, which is similar to the epithelial cells, reabsorbing majority of the substances and producing a final effluent containing of toxins, which comes out as the urine. Next slide, please. Next slide. So this is the connection where it is connected to the external iliac and internal iliac. So the advantages of the IAK is that it provides continuous filtration. The silicon being used as the narrow membrane protects it against that are there in the bioreactor. It produces a urine-like liquid waste of 2 to 4 liters of 120 ml per minute. What these artificial kidney or the implantable artificial kidney can provide is only 25% of that. So the clearance that it provides is only 30 cc per minute. Since these are foreign objects which are placed into the external iliac and internal iliac, they always carry the risk of thrombosis. And with respect to animal studies, a small pilot study of the IAK was done in dogs where the silicon membranes remain intact without leakage for a period of 8 days. So the last slide, so a comparison of the AVAC, VAC and IAK based on weight. The IAK is around 500 grams, still in animal models, and it requires invasive procedures. That would be one of the limitations of it. So, and as we now know in the world of chat GPT where AI is taking over everything, this is one of the concepts that is produced, that is the smart kidney, which involves artificial intelligence, artificial neural networks and machine learning. So we would have smartwatches which would monitor our dry weight, that is the amount of water in the body, the amount of fat in the body, the amount of sodium, potassium, and with the help of machine learning, it would decide how much dialysis is required for the patient. So that is what is being proposed for the future. Next slide, please. So my take-home message with respect to artificial kidney would be that human trials are awaited. It has been in the market for a long, long time. However, its human application again is a far-fetched reality. Smart kidney is an exciting development in the pipeline. Thank you for your patient attention. Thank you.
Thank Dr. Fahad for a wonderful presentation regarding artificial kidneys. Stem cells is something which is fascinating, not just in the field of nephrology, but other fields as well. Mainly, if you see in the last few decades, the applications of stem cells have been quite in the field of hematological malignancies. But the application in nephrology, whether it could be a reality, I don't think in the near future, but definitely there are a lot of studies which are going on with the application of stem cells. And as far as the artificial kidneys are concerned, we know the forms of renal replacement therapy, the hemodialysis and peritoneal dialysis, the problems dialysis. To some extent, transplant, tries to combat the problems associated with dialysis. But still, renal transplantation itself has got other problems and complications. The need for lifelong immunosuppression, the rejection rates are higher, and the infections and malignancies are long term. So whether we have a solution, complete solution for a patient with chronic kidney disease is, I think it's still a far-fetched dream. Whether come anyway close to the normal functioning kidney, I think whatever is there Till now, I think he's covered all the topics regarding that. I think only future will tell whether we can have a complete solution.
I have a few comments to make. One wonderful presentation. Such a dry topic. Give me a big hand. It's simply plus. Yeah. And such a difficult topic made easy because I put it 60%. Because what do is before CMEs, we have all this. We had an article kidney presented by Dr. Bijesh. Yeah. And brain by Dr. Aisha. So likewise, at least sensitize us to understand Latin and Greek, which goes over her head. So it was simply wonderful presentation. We may be successful, not today, tomorrow, but brain for artificial kidney should be RAS. Can we actually create a brain for
Can we create a brain
of kidney in form of RAS? Because auto-regulation is simply wonderful.
Yes.
Yeah, still we're trying to still figure out about actually trying to generate tubular cells, glomerular cells, your vascular, trying to make an artificial implantable. We may be successful with medicines. And again, of my lifetime, even if it's there, it is going to do 25% of the work. So where are we? Even if we actually spend so much of money, so he was telling us it is going to just filter about 25%. So where are we? 3, and in case if you are successful, kidney auto-regulates, and that is a brain RAS system. Can we may be having some depot where we're trying to put in erythropoietin there and it is going to be released. What about actually auto-regulation? These are the few questions for you.
Yes.
Yeah.
So based on what the implantable artificial kidney. So out of the AVAC and IAK, implantable artificial kidney is the closest that we are to make to the actual kidney, with the silicon membrane acting as the glomerulus and the cell bioreactor acting as the tubular cells. However, what function the tubular cells in that bricks or cell bioreactor is able to achieve is only the reabsorption. So as now, whether they would be able to have the RAS-like activity, it is difficult to predict, and I don't think it will be possible. And also goes to show that what we have and in our body that we take for granted is a really a work of art. What we can probably achieve with the artificial kidney at the max would be just fluid clearance, maintaining fluid balance of the body and the acid and electrolyte balance. If at all some endocrine function like erythropoietin, but auto regulation is something that I don't think would be achievable. Yes, yes, sir. Yes. Kidney on a chip, sir. That is not something that I've read or heard about. Though what they're trying to incorporate with chip technology is the smart kidney, that is with our smart watches and machine learning with artificial intelligence. But I don't think kidney on a chip is something that I've read about, or if someone is aware, they can.
Thanks for the excellent presentation. It is a very dry topic. Sunday afternoon, 1:30 is not a good time to discuss this subject. Just to add few things. I still remember as a first year PG in CNC Velo, 2002, I had similar topic which was given by my head of the department. So you do one seminar on artificial kidneys. See, in 2002 only, they were able to grow nephrons in the petri dish. But they were not able to connect different parts of the kidney. Like the kidney means it's not only the nephrons. There are other vascular compartment, there are tubular compartment. They were not able to do what to do with that. It's not that something new which is there in the market. They were able to artificially grow nephrons almost 20, 25 years back. But after that, we don't know. So it's like more you read, more you realize that you don't know. The knowledge is limited. I hope that this one day it will come. No, and there should not be a need for depending on organs from the other person, waiting like a vulture to get organs. So I hope that that will happen. But looks like God has his own plan actually. But I don't think it will happen in the near future also. This same artificial kidney is going on. Not we have not reached to human studies also. It is only in the animal models now. The same 20 years, the same story is going on. Governments, forget our government, lost lot of the developed countries, government spending billions of dollars. Yeah, yeah, yeah. Billions of dollars has been spent on this activity, but still we are very in a premature stage. Thank you, sir,
Thank you,
once
sir.
again.
Thank you.
Incidentally, this is live streaming is going on. So one actually ENT surgeon, he just sent a message. Dr. Parvez, Assalamu alaikum, mashallah, Dr. Fahad. Perfect dialogue, delivery, body language. You took us to a very high level of intellectual discussion, high level of zikr of our creator. A very complicated topic. You made it easy to understand and comprehend a little by layman like us too. It's a Jazakallah khair.
Thank you, Dr. Parvez.
Any more questions? Anybody has? So possibly last part of the job. Yeah. We are left here. 2, 3, 4 we have. Good. We started 10 minutes late and we are finishing 10 minutes before. Mustasab always says, come before time, leave after time. So we started after time and we're leaving before time. And anyway, there's a reason why we had 4 topics. Normally we used to have 6. Yeah. So we wanted to have actually interaction. There was lively interaction between all of us. So there are about nearly more than 1.2 lakhs, 1.2 million dialysis machines in every kidney. Each nephron is a wonderful dialysis machine. Yeah, it is actually not there were 1.2 million dialysis machines between few grams in every kidney. Yeah, imagine, and we're trying to replicate. And as rightly said, it is a far-fetched dream, but Almighty, He wants to see this creativity in us. It can happen, but especially these people who are in this actually today's CME, they have to take it as a passion. It should be a reality, if not today, tomorrow, if not in our life, after our death. If that actually so has to help, especially because repeatedly this word, though it is little pinching us, repeatedly telling us we are like vultures now for a good cause. And that too, actually, unfortunately, they don't die before time, so they can recover it. So whenever we want it, they don't die. When we don't want it, they die. So it's, basically, when we are in the chamber, it's not there. When the patients are there, we are not in the chamber. So that normally happens. So basically, this is going to be a big eye opener. So I really take this opportunity to thank Dr. Ishaq for actually here, coming here. She came over 2 weeks ago. I was keen. We need to create an awareness. I said, actually, we are not convinced about what you're telling. Yeah, we are confused. So we're going to everybody. First, let us be aware. And today, a lot of things actually are we are much clearer than what we are. Possibly, we are much wiser. I really take this opportunity to thank Dr. Ishaq for actually taking the lead role in having the CME today. And mashallah, Lord Dr. Aqil, yeah, his presentation was so wonderful. Fahad, mashallah, he was rattling and wonderful. And of course, our vice counselor, Dr. Ishtiaq, and Dr. Gopal here, and our Dr. Yusuf, Dr. Zahid, Dr. actually J.K. Prakash, Dr. Sridhar, and all are wonderful, but most wonderful all our delegates. We are not here, they would have been speaking to people, or possibly angels or somebody else. So all have done a wonderful job being here on a Sunday, and the last topic being artificial kidney, and Ishtiaq rightly put it, to see, keep attention Yeah, sustained attention. Yeah, is actually concentration, and that he was able to do that. Yeah, and a very important point to be taken back home is we should be holistic. So possibly a lesson for super speciality also is we need to be holistic. Yeah, we should pick values. Yeah, and keep telling a definition of super specialist is know more and more of less and less. The more we know, the less we know. The more we know. Ultimately, we have to surrender our arms before the Almighty. So basically, this is it. So we are much with confidence. Actually, final students diagnosis MS, and ultimately for MD fellow, it is actually it could be Austin Flint, it could be metal stenosis, and for a DM fellow, never to comment at all. He says do an echo. So that's how they go up. So basically, they don't want to exhibit their ignorance because actually they know too much, and ultimately they don't know anything. The leader. So this is what ultimately is what we've got today. We have limitations, but at the same time we have time. Actually, possibly in case if that is properly utilized, and this why not we give an artificial kidney to the whole world? Yeah, and why not? And that should be the attitude. With that passion we work, possibly in days so far, all the other legal, so many implications and complications that will take a back seat. I request Dr. Mushtaq to hand over a memento to Dr. Ishtiaq. Ishtiaq. Go ahead, please can come here. Dr. Nisar, or actually, there should be some role for pediatrician too. We have Dr. Nisar with us here. Hand over memento to Fahad. Well done, Fahad. Keep it up. Yeah. Can I request Dr. Bajesh? Come here. Hand over to Yusuf. Sir, can I request you, sir? Sir, please come. Hand over memento to Akhil. Youngest in the audience. What made you come, sir, here?
Sorry, I'm not a doctor. I'm a practicing advocate. I accompany my son. So even for legal issues could be understood. That's what I am here. Pardon? No, sir. We're not for that. Actually, advocates are not to sue anyone. They are there to protect. That's all. If he thinks otherwise, is right.
See the greatness. Natish called me last evening. He said, I want to attend. And thank you for coming, sir. We're very grateful to you. Yeah. Possibly, actually, it's the confluence of doctors, patients, all stakeholders, lawyers, judges, government, everybody jointly work for a common cause. Right? Actually, this is not a CM day. This is a social cause which Dr. does. On hands to make sure this man is taken care of. Now, actually, going to have lunch. Yeah, you can make and then possibly take off. We are, I think, so just we finished 5 minutes before. Thank you. Yeah, certificates you can collect. We can hand over certificates before they leave. That is going to make the job easy. If you actually came, they left. As usual, doctors are actually all the time they're busy. They have to go for the rounds, etc., etc. So if you people latecomers were there, but especially this we need to attend the word go till end. Make sure about it from next time. Yeah, so always it's going to give a lot of information. That is Ziaula. So he is in the Dr. Rajan Mohammed. Faraz Khan is actually critical care fellow. Come. Bushra. Zaid. Odd man out, na? He's doing his DM cardiology. So it's not Mustahsan. Nisar. Muhammad Yusuf. Ruknuddin has gone to round substance. Sadiq. Come. Abdul Aziz is left. Aqil. Ishtiyaq. You see that Ayah Khan ne barabar linga. Ayah Khan ne. Spelling is right. Sir. Sridhar. We'll give it to him. Zahid. Mushtaq sab. Dr. Gopal Krishna. Sir, you have been with us so nice till the end. Thank you. G.K. Prakash, we'll give it to him later. Shahid Goria. Recently cleared is actually DNB from here, but he's planning to do actually cardiology, if I'm right. Huh? No, it's changed actually after coming to the CME. Huh? Last week he told me damn cardio. Huh? So, good. No, Mujahid Parvez is on online. Dr. Shamita, anybody is here? Please come. Where are you from? Ma? Chikmagalur. What are you doing? Oh, good. Good. Naseem Seth, Ishtiaq Ahmed Khan, Zamir. Wonderfully sustained attention is concentration. Zamir, from the word go till end. You need to be Allah. Altaf. Sadi Alvin. Zafrul Haq. Umesh. Aishwarya. She's our DNB PG medicine. Muhammad Fahad Khan. Santosh is nice. Yeah, Yogaraj is left. Nisar. Santosh, come. Yogaraj is here. Come. He came with Naseem. Can we hand over Dr. Naseem to you? Naseem was here, but he had to leave just now. Yasmin, Firdos, Shuaib, Faizan Ahmad Ansari, anybody? Please. Asha online. Kalimullah, Nadeem Pasha, Pasha, Parveen Yusuf, all online. Nadeem Riaz is in the ICU. Khadir, come. Bijesh. Anybody who are left out, in case you have come directly here, unfortunately, we cannot issue a certificate to them because 48 hours before, we need to send it to KMC and get it signed. So anyway, attendance is more important than getting a certificate of CME. So now anyway, we have actually finished. Thanks for coming. And we are going to start the CME to have every monthly. We are going to select topics of common interest. One thing we normally do is we don't take help of any pharmaceuticals. Medicine was never sold in life, actually in history. Food was never sold. Knowledge was never sold. Three most commercialized industries in the world: hotel industry, health industry, and education industry, where we need to bring it to zero and possibly do away with pharmaceuticals, especially so, which is definitely a call working to promote unwanted. So basically, this is a forum where we make sure every second month we are going to start again. We used to have pre-cold, we were busy. So we started on the good note with kidney. It's going to be alternate month. This is Feb, right? So even months we're going to have it. So we can keep first Sunday free, and we're going to notify. Thanks for coming. We'll join for lunch.